Okay, why don't we get started? Good afternoon, everybody. This is CTPL01, Multimodality Immuno-oncology Approaches. My name is Louis Weiner. I'm director of the Georgetown Lombardi Comprehensive Cancer Center and the MedStar Georgetown Cancer Institute in Washington, D.C. And it's a real pleasure to be able to share with you, the exciting results that will be presented in this session. It's been a long time in coming, and I note that we were symbolically placed in a room where the pillars are shaped like monoclonal antibodies. Has anybody noticed that? And thank you to James Gully for pointing out that fact to me, but it's symbolic. And like the old days, we've been a little bit banished to Siberia in terms of the location of the room, but it's a large room, and it's wonderful to see so many people coming to hear what will be presented today. I'll just have one minor comment to make. So in preparation for this session, I was wondering, because we all are well aware of the proliferation of interest in the clinical science related to immunotherapy for cancer. So I did a completely unscientific, very anecdotal review of PubMed, looking up only one term, and just for the sake of shorthand, it was PD-1. And what I can tell you is the number of PD-1 citations prior to 2000, the grand total was 1. And from 2001 to 2005, it was 3. From 2006 through 2010, it was 31. From 2011 to 2015, 281. And since 2015, 728 with a bullet. So it's really an extraordinary asymptote of just really dramatic increases in the number of publications. And that, of course, has been mirrored by the clinical trial activity focused on immuno-oncology over the past 5 years or so. And we'll be hearing a lot about that today. So without further ado, I'm going to introduce our first presenter. And the title is, as you can see, Preoperative Pembrolizumab Before Radical Cystectomy for Muscle-Invasive Urothelial Bladder Carcinoma, Interim Clinical and Biomarker Findings from the Phase 2 PURE-01 study. And presenting for the group will be Dr. Necki. Dr. Necki?
Thank you, Mr. Chairman. Welcome, everybody. It's a real pleasure to be here presenting the first interim results of the Phase 2 study, which is an academic study, two-center study led in Milan in urothelial bladder cancer, muscle-invasive bladder cancer, PURE-01 study. Here is my disclosure. Of course, we will deal with the off-label use of pembrolizumab in non-metastatic bladder cancer. As you know, muscle-invasive bladder cancer is a high-risk disease by definition, and the higher metastatic relapse rate suggests that this may be a deadly disease even in the absence of clinically lymph node involvement. And for these patients, paradoxically, despite that there is a recommendation, a level 1 recommendation to use cisplatin-based neoadjuvant chemotherapy. Chemotherapy is administered in about 20% of patients worldwide, in Europe as well as United States, for a number of reasons. And there is a lack of effective treatment in patients who cannot receive cisplatin-based chemotherapy, and the identification of genomic predictors and biomarkers for response and benefit from neoadjuvant chemotherapy is still at the very beginning. On the other side, immune checkpoint inhibitors are revolutionizing the therapeutic landscape of urothelial cancer, on metastatic bladder cancer. Pembrolizumab is already approved, FDA and EMA approved for locally advanced and metastatic urothelial cancer after platinum failure, as well as for cisplatin ineligible patients in first line. And in the PURE study, it is used as a single agent, as a short course neoadjuvant therapy in non-metastatic muscle-invasive bladder cancer, and the first interim analysis is presented. The inclusion criteria for this study are as follows. Patients should be fit and planned for radical cystectomy, of course. Predominant UC histology. Clinical T2 and 3B N0 stage. Residual disease after TUR, meaning that we were trying to minimize the bias of complete pathologic response after TUR, which is an historical bias for all neoadjuvant treatments and for all neoadjuvant studies in this disease. We are including cisplatin eligible and ineligible patients, minimum GFR 20, ECO-PF performance status 0-1. The assumption for two-stage design are H1 of 25% response, pathologic complete response rate. Pathologic complete response is the primary endpoint of an ITT population. And the null hypothesis is 15%. These are two benchmarks for cystectomy, TUR only, and neoadjuvant cisplatin-based chemotherapy, cisgem or MVAC chemotherapy, 25% pathologic complete response rate. 71 patients are expected to be enrolled overall, with the 43 patients at first step, 80% power. This is the design. Patients are receiving 3 cycles every 3 weeks of neoadjuvant pembrolizumab. Patients are staged with CT scan, thorax and abdominal CT scan, PET CT scan, and multiparametric bladder MRI for translational purposes, and then are restaged with the same tools after the 3 cycles of pembrolizumab. Then, at this point, at this stage, patient should be given additional chemotherapy, should be judged as failure by the investigator, and should be given additional dose-dense and VAC chemotherapy if they are judged according to radiological examination to be non-responders before receiving radical cystectomy. And the post-treatment phase is according to the guidelines, to the routine practice, adjuvant chemotherapy observation according to the risk of relapse, and survival data are collected until 2 years. The biomarkers, PD-L1 expression, immunohistochemistry is assessed with the dacoclone 22C3, and we rely upon the CPS, the combined positivity score, which is calculated, which has been used already in pembrolizumab studies in the metastatic setting, and is already counting the number of total staining cells, including tumor cells, lymphocyte, macrophage, so in microenvironment also, over the total number of viable tumor cells. And also the genomic sequencing is centralized to Foundation Medicine, and the Foundation 1 assays has been used for all samples before and after treatment, and it will be the objective of this presentation. Of course, there are a number of additional immunologic studies that have not been presented here at this meeting. Here is the situation of the study, the population of analysis, accrual status. In 1 year, the study started in February last year, and in 1 year we accrued 50 patients. This is one of the good news for neoadjuvant treatments in 2 centers. The NGS analyses are available for all patients at first stage, and the efficacy analysis, as well as PD-L1 CPS, is available for the first 36 patients that are the objective of this presentation, the 36 patients for whom the pathologic response is already available. The general characteristics are explained here. There were 20 patients with clinical T3 disease. There were also 2 patients who were included with actually an N1 disease at the clinical staging. 7 patients presented with adenephrosis. 5 patients had an history of non-muscle invasive disease. 5 patients received additional dose-dense and VAC chemotherapy after pembrolizumab. All patients were cisplatin eligible according to the Galsky criteria, 100%. And all the rest of the surgical characteristics are those quite similar to the standard practice. The total the time from the end of pembrolizumab to radical cystectomy is a median of 22 days, meaning that the total treatment period from the day 1 pembrolizumab to radical cystectomy is 62 days, 2 months. And we are trying to lower this time frame, and these last 10 patients, for example, the time from end pembrolizumab to the last course of pembrolizumab to radical cystectomy was only 2 weeks, and we are trying to further lower this period to 1 week only. The CPS score, the median CPS was 23%. TMB was greater than 20 mutations per megabyte in only 3 patients, but was greater than 10 mutations per megabyte in more than half of this patient population. And all patients were microsatellite stable tumor. These are the adverse events that are quite similar to those reported in metastatic disease. The most frequent immune-related adverse event is thyroid dysfunction, of course. Interestingly, there were a few late-onset adverse events, immune-related adverse events like postoperative pruritus, pyrexia, xerostomia, alopecia, meaning that the follow-up of this patient is still too short to drive any definitive conclusion regarding long-term side effects of non-chemotherapy treated patients like these patients, this patient population. Regarding surgical sequelae, we can say that we cannot see any quite different signal toward the routine practice. All these patients underwent enhanced recovery protocols after radical cystectomy. And of course, major issues were not encountered so far in these patients. These are the pathologic responses to pembrolizumab. In all treated patients, we have 14 pathologic complete responses, 38.9%, and 18 patients, 50%, there were a downstaging to non-muscle invasive disease. Importantly, 5 patients, as I mentioned, received additional chemotherapy because they were judged as clinical failure, but none of these patients already treated so far experienced and received disease progression while on pembrolizumab treatment. This is an important point. And including and considering only the PD-L1 CPS score greater than 23%, which is the median value, 9 patients, 47.4%, achieved a complete pathologic complete response, 57.9% pathologic downstaging to non-muscle invasive disease. There was a significant difference in CPS score between pathologic complete responders and pathologic non-complete responders patients. And of course, out of the 5 patients who received additional chemotherapy, 2 of them were downstaged to non-muscle invasive disease, 40%. These are the genomic alterations that were observed in this patient population. Interestingly, the retinoblastoma gene alteration was the only one that was significantly associated with pathologic complete response as a single gene alteration. Interestingly, there is also the signal toward FGF receptor 3 alteration as associated with the non-response or non-complete response to neoadjuvant pembrolizumab, paralleling the results already achieved in the metastatic setting regarding this biomarker. Regarding the DNA damage response and repair genes that have been associated with the response to pembrolizumab in the metastatic setting, and we have evaluated all of the patients at the first stage, 43 patients, and 42% of this patient population had the DDR gene alteration. And there was a trend toward an association between DDR gene alteration and higher tumor mutational burden, because the median mutational burden for DDR positive gene positive patients was 14 compared to 9 in the DDR negative patients. And if we use this information to better dissect the results, we see that the DDR gene alteration were present in 15 patients, 42 patients in this population of analysis. DDR gene alteration plus or minus PD-L1 CPS greater than 23% is observed in 77.8% in this patient population. DDR gene alteration plus PD-L1 greater than 23%, so the combination of the two is seen in 14% of patients. And this patient population, you can see here the responses, pathologic complete responses, that have been achieved in 60% of patients with DDR gene alteration, 46.4% in patients with DDR gene plus or minus PD-L1 CPS greater than 20%, and in all the 5 patients, 100%, who had both DDR gene alteration and PD-L1 CPS greater than 23%. You can see also the pathologic downstaging rates. There is a trend towards higher tumor mutational burden in complete responders versus non-complete responders, even though the trend is not so clear like for PD-L1 expression. PD-L1 positivity, PD-L1 CPS did not correlate with neither tumor mutational burden on the left or DDR gene alteration on the right. Interestingly, the median CPS in DDR gene positive patient was only 10% versus the 30% CPS score median in DDR gene unaltered patients. So this, so the two signals seem to be divergent, meaning that probably they are measuring different biologic features. Regarding the patients who had matched pre and post tumors for comparison, these results should be kept as preliminary because further analyses are ongoing, and at least in 5 patients post-treatment, there is a low tumor purity that may hamper the final results, but in any case, results are pretty much overlapping those already reported in the chemotherapy setting. There is a mean of 50.7% of shared alteration between pre and post tumors. 44.3% of cancer-related genomic alteration are lost, and 80% of cancer-related genomic alteration are new after pembrolizumab treatment. Interestingly, among the genomic alteration that are lost in the post-pembrolizumab treatment, post-pembrolizumab setting, there are 3 cases for whom FGF receptor alteration are lost in the post-treatment tumor, as well as another patient for whom there is a shared mutation of FGF receptor 3. Additionally, the pre versus post-therapy tumor mutational burden is shown here. The median TMB after treatment is 5.7 mutation per megabyte versus 9.6 mutation per megabyte in the pre-therapy tissue. I'm sorry. And regarding PD-L1 CPS, higher level of CPS is observed after treatment with pembrolizumab compared to baseline. Here are some cases. Here is a case with the lymphoepithelioma-like variant urothelial cancer showing amplification of both PD-L1 and PD-L2 genes, leading to a 95% CPS in the TOR tissue and achieving an outstanding response and pathologic complete response. Another case showing a 99% of CPS in the TOR tissue, harboring a BRCA1 mutation and achieving again pathologic complete response, starting with the 3-3 advanced disease. What about radiology? We have cases like this one, showing a good morphologic response in tumor thickness and being associated with pathologic complete response, but this is not always this case. The radiological assessment is still a matter of further research. And this is the reason why we are using additional parameters like multiparametric MRI to try to see whether we may identify additional tools to evaluate and to predict pathologic complete response, like ADC, for example, in this case, who achieved the pathologic good response, a good downstaging after pembrolizumab. But this is still a matter of debate because even the use of additional parameters is still requires additional cases. There is not always like this case. So in conclusion, we presented the first yet preliminary data of neoadjuvant immune checkpoint inhibitors in muscle-invasive non-metastatic bladder cancer. Pembrolizumab was safe and confirmed to be safe in chemotherapy and treated patients, and endowed with potent biological and clinical activity in this patient population. In particular, the presence of DDR gene alteration and probably associated with the retinoblastomas alteration with or without PD-L1 CPS may be very strong biomarker for response, for complete response to pembrolizumab treatment. Interestingly, the discrepancy between pre- and post-tumor tissue may suggest a number of potential additional studies of combination or sequential treatments, meaning, for example, an interesting point is the use of FGF receptor inhibitors in this context based on the modulation of FGF receptor 3 alteration before and after treatment with pembrolizumab. The ongoing steps forward at our center are as follows. We are including in an amendment an additional cohort of 20 patients with upper tract tumors, meaning high risk according to EAU guidelines, node-negative tumors of the upper tract receiving pembro for 3 cycles before radical nephroenterectomy. We are evaluating IDO1 as an additional biomarker because we are opening an additional study in the same design with pembrolizumab and the paclitaxel in muscle-invasive bladder cancer. Of course, a lot of immune cell expression signature may be found as intriguingly associated with TMB, genomic alteration of PD-L1 expression, and this data will be presumably presented at ASCO this year. And of course, the other point will be the use of a multiparametric MRI to predict before radical surgery those who have achieved already pathologic complete response, and full biomarker results on the 43 patient population will be presented at ASCO here again in Chicago this year. With that, I would thank you. I would thank first of all the patient and their outstanding involvement in this and continuing involvement in this protocol and in other similar protocols in this very, very intriguing but challenging field of bladder cancer. Of course, my colleagues from the study sponsor institution, from the INT in Milan, people from the Urological Research Institute in San Raffaele who contributed an outstanding number of patients in 1 year, and people from Foundation Medicine who are generating hypotheses on tumor tissue together with investigators. And I would thank you all for your attention. Thank you.
Thank you very much, Dr. Necchi. To present this very interesting, a review of this very interesting presentation, we're pleased to have Dr. James Scully from the National Cancer Institute. James.
Thank you, Lou. So it's my pleasure to be here today to try and put this into a little bit of clinical context for you. If we could have my slides. So I have no relevant financial disclosures. So bladder cancer is a common, aggressive, and lethal cancer, and it is an expensive malignancy to treat. Risk factors for metastatic disease at diagnosis are twofold in blacks in America compared with whites. For purposes of treatment strategies, bladder cancer can be divided into 3 categories: mucosal confined disease, recurrent or muscle invasive disease, and metastatic disease. For patients with mucosal confined disease, intravesical therapy is often used. BCG's use was first described in 1976. It was approved in 1990 for non-muscle invasive bladder cancer. It causes inflammation and induction of type 1 cytokines. It is one of the earliest effective immunotherapies firmly planting bladder cancer as an immune-responsive disease. For patients with muscle-invasive disease or recurrent disease, cystectomy is often used in combination with neoadjuvant chemotherapy. The data for the use of neoadjuvant chemotherapy comes in part from this study published in the New England Journal of Medicine in 2003. This study compared patients getting MVAC chemotherapy prior to cystectomy versus cystectomy alone, and the MVAC chemotherapy was associated with increased pathologic T0 response as well as improved overall survival. However, it was associated with a third of the patients having grade 3 adverse events and a third having grade 4 adverse events. But this pathologic T0 is actually important As you can see here in this more recent study from 2014, this meta-analysis included 12 studies looking at the pathologic T0 rate, and there was a 55% decrease in the rate of death, as you can see here with this meta-analysis. Unfortunately, not everybody gets neoadjuvant chemotherapy at this point, and that's for a variety of different reasons. There has been a continued increase in the number of patients getting neoadjuvant chemotherapy. You can see in this study published in 2014, there's a 20% increase from 10%. And in this study from the Netherlands, in over 10,000 patients, this increase was up to about 10% by 2013. However, in part because of patient fitness and because of the side effect profile, neoadjuvant therapy is not used in all patients. For patients with metastatic bladder cancer, until recently, chemotherapy has been the standard of care. However, because there's a relatively high tumor mutation burden in bladder cancer, which is associated with a higher likelihood of neoantigens, immunotherapy makes sense. And so initial studies with PD-1 or PD-L1 inhibitors showed that there was activity of these agents, and this led to further studies and led eventually to second-line approval in the last several years of these PD-1 or PD-L1 targeted agents, and then also approval of atezolizumab and pembrolizumab in first line. There's been an effort to push this earlier on in the disease course, and so you see 3 phase 3 trials now looking at PD-1 and PD-L1 targeted agents in the adjuvant setting following cystectomy in patients with high-risk muscle-invasive bladder cancer. However, this study that we're talking about today is in the neoadjuvant setting prior to cystectomy, and you're seeing this short course of neoadjuvant treatment with 3 cycles of pembrolizumab given every 3 weeks. Overall survival and progression-free survival data will be collected out through 2 years. I want to draw your attention to 2 important things here. First of all, in the inclusion criteria, there was a requirement for residual disease after TURBT. Second, I just want to redraw your attention to the pathologic T0 rate of 25% or more being considered a positive study. So how did the patients do on this study? Well, the primary endpoint was the pathologic complete response, or PT0. And you can see here about 39% of the patients had a PT0. If you were also PD-L1 positive, you had a response rate approaching 50%. How does this compare with what patients would have done with chemotherapy? Well, in this setting, dose-dense MVAC is the chemotherapy that is most frequently used. Last year, there was a meta-analysis of 10 trials suggesting a pathologic T0 rate of about 27.8%. So I would argue that this is a clinically meaningful improvement. And I would also note that these patients, remember, had to have residual disease at time of treatment. So this is interesting because in this study, it was shown that 38% of the pathologic response could be attributed to the transurethral resection, suggesting that an incomplete or leaving some tumor behind, you're going to be associated with a less of a pathologic response. While these numbers certainly are interesting, I would say that they are still small yet, and the efficacy results are not available through the first stage, which is at the 43 patients. So there's 7 patients where we still haven't had the surgery, and so we don't have the data. However, even if there were no responses in those patients, they will still have surpassed the threshold for moving to the second stage. In terms of side effects, I think this was very well tolerated. These 3 cycles, you see very few grade 3 and 4 adverse events. There were some late onset events, and the surgical sequelae there was no signals of increased toxicity in this neoadjuvant study. while we can't compare this head-to-head with what you would expect with chemotherapy, there are studies that have compared head-to-head PD-1 and PD-L1 inhibitors compared with chemotherapy. And this was a meta-analysis that was published last year suggesting that high-grade events were decreased by about 70% if you got PD-1 and PD-L1 versus chemotherapy, and the risk for treatment discontinuation was about 55% lower if you had PD-1 or PD-L1 versus chemotherapy. This was an interesting finding here where you look at the RB1 tumor suppressor gene, and if there's mutations in there, you see about 80% of those patients that had that mutation had a pathologic T0. Now, small numbers, but interesting, and if these numbers hold up, could be clinically meaningful, because if you look at the TCGA database, about 25% of patients with bladder cancer have a mutation in RB1. In addition, the genomic alterations in DNA damage response pathway genes were interesting too. So if there was about a 60% response rate if you had a DNA damage response mutation, and if you took the subset of patients that also were PD-L1 positive, you could see 5 out of 5 of those patients having a pathologic T0. Very small numbers, hypothesis generating, but there is additional data in bladder cancer and checkpoint inhibition suggesting improved response rate with patients who have DNA damage response mutations. So this is in patients with metastatic disease, suggesting, that was just published last month, suggesting that there's a doubling in the response rate if you have a DNA damage response mutation. Finally, I think that this data from 2003 that was used to approve MVAC is interesting, because what you can see here in the upper two curves here is patients that have a pathologic T0, whether or not they got chemotherapy, and in the bottom here, if they didn't have a pathologic T0, whether or not they got chemotherapy. So chemotherapy wasn't the bigger driver in this, it was actually getting to that pathologic T0. So using the author's conclusions, I think these data are preliminary, and I think they're interesting. Pembrolizumab is safe, and I think there's a clear anti-tumor signal in muscle-invasive urothelial bladder cancer. Presence of DDR gene alterations may be an important predictor of activity. So does this change the standard of care? No, but I think these are promising data, and I think that these data are foundational for future studies. And could the future include no radical cystectomy for appropriately selected patients? Well, we don't really know about this yet, but I would say that this is tantalizing, and if one could avoid radical cystectomy, you'd avoid a lot of morbidities, but clearly we need much more data. Thank you.
Thank you, James, for that excellent presentation. Our next presentation is CT-004, which is frontline therapy of DIPG using the IDO pathway inhibitor Indoximod in combination with radiation chemotherapy. And this will be presented by Dr. Johnson from the Georgia Cancer Center in Augusta, Georgia. Dr. Johnson.
So I want to thank you for the opportunity to present results from a pediatric study. We think that the trial design has got a high degree of novelty, and we're happy to be here today to tell you about it. So these are my disclosures. I will be talking about off-label use of chemotherapy drugs today for children. IDO is a natural immune regulatory mechanism. It works by degrading tryptophan. And if a tumor can interact with the body's immune system in a way that turns IDO on, then tryptophan is degraded and immune responses are suppressed. The key point is that IDO is a natural mechanism of immune suppression and tolerance. The most important thing for the multimodal chemotherapy, radiation, immunotherapy approach that I'm going to talk about today is that IDO maintains tolerance to apoptotic cells. So we hypothesize that if you block IDO, then you can break that tolerance and recruit the immune system to help fight the cancer. IDO expression is generally associated with poor outcomes across a variety of tumor types. This is a plot that shows IDO expression in draining lymph nodes from melanoma patients and adult cancer patients, correlating with poor outcome. So Indoximod is the drug that we use in the study. Indoximod inhibits the effects of IDO pathway. It's orally bioavailable, and it's generally well tolerated across multiple clinical studies to date. From preclinical studies, we know that IDO inhibits the effects of tryptophan degradation in ways that allow the proliferation of T cells previously suppressed by IDO. Indoximod also interacts directly with regulatory T cells in ways that seem to destabilize them. And IDO also modifies the phenotype of antigen-presenting cells, including decreasing IDO expression itself. And here's an example. Here's an example. And for additional detail on the mechanistic studies, please go by Eric Brinks' poster, which is going to be presented on Tuesday morning at this conference. So the slide is laid out in, these are isolated CD4 cells from human donors that co-express CD25. And on the y-axis on the left-hand side is the percentage of these cells after in vitro activation that express FOXP3, and the right-hand y-axis is expression of IL-17. The x-axes are titration of drug concentration. So normally, these CD4 T cells activate FOXP3 under these conditions, but when exposed to IDO, Indoximod, they suppress FOXP3 expression, and begin to upregulate pro-inflammatory genes, including IL-17. Interestingly, other IDO inhibitors don't have this direct effects on regulatory T cells, and IDO therefore has a differentiated mechanism of action that we think is important in its immunological effects in vivo. So this might be probably the most important slide of the talk, actually, because it's the hypothesis that drives our multimodal chemotherapy, radiation, immunotherapy combined approach. The patients that enrolled on this study were pediatric brain tumor patients who were refractory or relapsed and known to be minimally responsive to conventional therapies. So our hypothesis was that if you could activate the immune system, then you could rescue responsiveness to chemotherapy and radiation in these totally refractory patients. The key point is that not just any form of immune activation will synergize with chemotherapy and radiation. Our hypothesis was that in order for chemotherapy and radiation to synergize with immunotherapy, the immunotherapy has to be able to break tolerance to the dying apoptotic tumor cells. And importantly, it's the antigen presenting step that is a key checkpoint that lies upstream of T cell checkpoints. So the patients that we treated on this trial were children with brain tumors, either refractory or relapsed, usually multiply pretreated and often with widely metastatic disease. And so the take-home point is that these patients can't be cured with currently available therapies. The graph to the right shows an aggregation of published data in the last 5 years, showing how these patients do with PFS and overall survival. Essentially, by 6 months after relapse, only about, well, less than 50% are still alive, and that number drops to less than 20% at 12 months, so it's a very grim setting. So the trial that we conducted was a first-in-children phase 1 trial using Indoximod-based therapy. The structure of the trial was made to seamlessly integrate this immunotherapy with both chemotherapy and radiation therapy. And so the chemotherapy and radiation was so integrated into the trial design that we actually had to do 2 separate dose escalations of Indoximod in combination with either radiation or with temozolomide in order to find recommended phase 2 doses. So this was a phase 1 trial comprised of a mixed population of pediatric ependymoma, malignant glioma, and medulloblastoma patients. This is a daunting slide, but I'm going to walk you through it and spend some time on this. This is the first patient that we enrolled and the longest patient treated on Indoximod. It's a really great example of what we mean by multimodal therapy. This patient's received continuous Indoximod therapy for over 2 years in combination with multiple surgeries, multiple radiation plans to different tumors, and multiple chemotherapy plans. And this patient continues to have objective responses. So on the timeline here, the red blocks represent periods of progressive disease, and the blue lines represent periods of responsive disease. So this patient came in with multiply recurrent, widely metastatic, progressing ependymoma, and we were able to start him on Indoximod and targeted radiation to a subset of his metastatic lesions. We didn't radiate all of them, followed by Indoximod combined with cycles of temozolomide. He achieved a partial response, but about 5 months into therapy, he developed progressive disease in his primary posterior fossa tumor, a site that we were unable to irradiate at the beginning due to prior radiation doses. So we treated this with continued Indoximod therapy, surgical resection of the posterior fossa tumor, radiation to additional metastatic lesions, and switching the chemotherapy to a second-line chemotherapy plan. So it's important to say here that the rationale for continuing the Indoximod in this setting is that the trial itself is predicated on the prediction that the immune system may actually be getting more responsive to chemotherapy and radiation as time goes on and patients get more cycles. So this patient developed stabilization of disease followed by a late response that lasted over a year. Around almost 2 years into his Indoximod-based therapy, he had another progression with progression in new tumors that were intraventricular. So we continued Indoximod again, radiated the sites of new progression, surgically excised sites of accessible disease, and switched his chemo to a third chemotherapy plan. And he developed an objective response again. So it's important to remember that this type of patient in pediatrics is completely unsalvageable, and these patients don't respond to conventional therapies very well. So his refractory progressive disease was stabilized and became responsive using Indoximod-based multimodal immunotherapy. And here's an example of one of the lesions that we treated with Indoximod and 20 gray of additional radiation in conjunction with third-line chemotherapy. And so this lesion is responding after a few cycles of that and the radiation. But importantly, even tumors that were outside the radiation field began to respond to this regimen. So we can't say that that's an abscopal response to radiation because the patient's also on chemotherapy and immunotherapy. But the patient is having abscopal control of lesions that lie outside of the planned radiation fields. So That's a long time to spend on one patient. But I just want to make the point that every patient that achieves long-term disease control is very unique. And also that setup was important to illustrate the fact that progressive disease and PFS are really not adequate outcome measures in order to measure the true benefit that these children are receiving on this multimodal therapy. So remembering that the goal of the trial is to create sustained responsiveness to chemotherapy and radiation, we use time to regimen failure as an outcome measure. So time to regimen failure is defined as when we had an escape lesion that we could no longer control. The strategy was not to take patients off the trial as soon as they had their first progression, but instead to adapt the conventional management in order to get things back under control. So this is a Kaplan-Meier curve showing aggregate data from the first 29 patients that enrolled in the study and filled the 2 dose escalations that we ran in tandem. All of these patients were enrolled with relapse refractory disease, and many were heavily pretreated. And so even without radiation, we're seeing a substantial proportion of patients who do achieve long-term disease control. When you add radiation, which is the red line here, you get an increase in time to regimen failure as well. So here's an example of why we don't just take patients off treatment at the first sign of progression. This is, and also why we think time to regimen failure is an important outcome metric. This is a young lady who we enrolled on the basis of isolated spinal fluid relapse of medulloblastoma, who did not have an anatomic lesion at the time of study entry. However, after 2 cycles of chemo Indoximod, she developed a contrast-enhancing mass at the base of her thecal sac that then stabilized and began to regress by 6 cycles of therapy. This patient has now achieved long-term disease control. She's had negative spinal fluid for over 12 months and just started her 14th cycle of therapy. From a quality of life point of view, she's a competitive volleyball player and she's one of the captains on her team. So overall, the multimodal Indoximod-based combination therapy was very well tolerated in the children that we enrolled. And we wanted to think about moving to upfront therapy. So the ideal place for this type of multimodal approach, we think, is frontline. The advantage of this integrated chemotherapy radiation with Indoximod-immunotherapy approach is that it's readily translatable to frontline therapy. And so we went forward with a DIPG cohort in frontline therapy using exactly the same regimen. So Indoximod combined with upfront radiation followed by cycles of Indoximod combined with temozolomide. So we chose to treat diffuse intrinsic pontine glioma patients, DIPG, because the disease is ruthlessly progressive, it's uniformly fatal, and there have essentially been no major advances in treating this disease for 40 years. Because effective treatments for DIPG are lacking, we thought it was appropriate to introduce immunotherapy in the frontline setting. But the brainstem is a very bad place to have a tumor. And so we were concerned that if we got on-target inflammatory responses in the brainstem, that could cause local edema that may aggravate severe presenting symptoms and even put the patient at risk for herniation. So the first question we had really was whether these DIPG patients could even tolerate this treatment. We've now enrolled 8 patients, but we've got 6 patients who have completed radiation Indoximod upfront therapy with radiation Indoximod. And those 6 patients all tolerated the Indoximod radiation cycle very well. They all finished their radiation plans. All 6 showed improvements in their presenting symptoms. Some patients later had additional symptoms that we managed symptomatically, but all these patients remain on Indoximod-based therapy. So we've seen a range of responses. And here's an example of a patient who came in with a very large pontine mass. It's a 9-year-old little boy who plays football and suffered a concussion on the field, and incidental finding on his CT scan in the ER showed this mass. So the slide is laid out with serial cuts in the coronal plane across the slide. The pre-treatment MRI is on the front row, or the top row, and the post-radiation MRI is on the bottom row. So he tolerated 6 weeks of Indoximod radiation very well, and afterward, he essentially had no evaluable signal in the T2 flare images. Importantly, he's neurologically normal 6 months into therapy. We just got a new MRI scan on him, and it's essentially the same as his post-radiation scan. So this is another patient who had a very large pontine mass. He tolerated his 6 weeks of Indoximod immunotherapy very, very well, and he remains, he had significant neurological improvements that have been sustained into 6 months of therapy as well. And he recently also had a repeat MRI that shows promising radiographic response. So the important thing, and these are the other 4 patients in the cohort of 6 with pre-radiation and post-radiation scans. So the important thing is that all of the DIPG patients we've treated so far have tolerated the treatment very well, despite our initial misgivings and our concerns that the brainstem location would be problematic for immunotherapy. These kids are tolerating it extremely well. All the patients have had symptomatic improvement in their presenting symptoms, and all the patients remain on Indoximod-based therapy. We're actively enrolling newly diagnosed DIPG patients into the study. So to conclude, maybe a little early, this phase 1 data suggests that Indoximod-based immunotherapy can allow disease responsiveness to conventional therapy. And this is not the population where you would think that conventional chemotherapy and radiation would have a big impact. Also in these children, the combined multimodal approach of chemotherapy, radiation, Indoximod has been very well tolerated to date, and we're very happy about that. So the pilot cohort enrolling newly diagnosed DIPG patients is underway. We're actively enrolling that, and we have phase 2 studies in the planning stage. And of course, I'd like to thank all of our collaborators. Everybody here has made a huge contribution to this study, and there are many referring physicians and collaborators around the country who are sending us patients. Also, Newlink Genetics Corporation, who is the industry sponsor for the study, and Alex's Lemonade Stand Foundation, and our other foundation supporters. Thank you.
Thank you, Dr. Johnson, for this provocative and interesting study. To discuss this, we're going to invite Derek Wainwright from Northwestern University to offer a perspective on the findings.
Thank you to the organizers for inviting me to provide my perspective on Dr. Johnson's work. I'm not a physician. I'm an assistant professor at Northwestern University. My laboratory primarily focuses on IDO and really the non-canonical functions of IDO in cancer, specifically in adult glioblastoma, which I want to highlight that I am not an aficionado nor an expert in the context of DIPG, but we do have a DIPG project that's being heralded by a hem-onc fellow in my laboratory who has a primary appointment at Lurie Children's Hospital, which is right across the street from Northwestern. So I'm going to provide maybe a little bit of a unique perspective and hopefully illuminate some of the IDO intrinsic effects that are not widely appreciated. I'm exceptionally unimportant and therefore I have no disclaimers. So just to sort of recapitulate some of the talk from Dr. Johnson, we're primarily focusing on brainstem gliomas. 10 to 20% of all CNS tumors in children are brainstem gliomas. They're much more common in children than they are in adults, and they're the leading cause of brain tumor-related death in children. And it's also notable that in 2016, more children died from a tumor in the brain than from any other cancer, including leukemia. So brain tumor-related mortality in children is a growing problem. Part of the reason for that is leukemia is becoming a treatable disease, whereas brain tumors in children are still pretty much incurable, especially when they're in the brainstem. Diffuse intrinsic pontine glioma has a mean age at diagnosis of 7 to 9 years old. Males and females are equally affected, and it's very, very rare, thank God. It only afflicts approximately 200 to 300 children in the US per year. So if we were looking at the brain in this particular schematic, this is the site where DIPG normally resides. Children diagnosed with DIPG obviously have a grim prognosis. An untreated diagnosis is associated with 6 to 7 month overall survival. Radiation treatment extends the survival by approximately 3 to 4 months to an overall survival of 10 to 12 months. Historically, chemotherapy has not been shown to increase overall survival for the treatment of children with DIPG. So the question here, and there's obviously a directionality toward IDO1, but the question is, what other targets can we go after in the context of DIPG for potential synergy with radiotherapy and chemotherapy? I want to highlight the study by Dr. Johnson's group at Georgia that really brought this to the forefront of potentially combining radiotherapy, chemotherapy, and Indoximod for the treatment of brain tumors. But before I do that, I just want to highlight what IDO1 does. IDO1 is a tryptophan catabolic enzyme. Tryptophan, most notably, is an essential amino acid. We can only take it in through our diet. We cannot create it within our own bodies. It's used in the serotonergic pathway via tryptophan hydroxylase, and it's also a building block in all of our proteins. But ultimately, tryptophan can be converted into kynurenine, and then through a series of other enzyme-related reactions into NAD and ATP. So it's an energetic production pathway under normal circumstances. It's also important to highlight that there are multiple tryptophan catabolic enzymes in our body. Tryptophan dioxygenase is constitutively expressed in the liver. Notably, IDO is not expressed in the liver. And so there's multiple tryptophan catabolic enzymes, and therefore it sort of increases the complexity as far as how to target this particular process in cancer. So to highlight some of the data from Dr. Johnson's group, he previously showed that combining radiotherapy with TMZ, which is our standard chemotherapeutic drug, especially for the treatment of adult glioblastoma patients, and Indoximod leads to increased survival in a glioma model. I've adapted this just to make it a little bit easier to understand. What they did was they intracranially implanted murine syngeneic glioblastoma cells and then followed post-intracranial injection with a dose of temozolomide followed by a dose of radiotherapy, and this was concurrent with continuous administration of dextrorotary 1-methyltryptophan, which is also known as Indoximod. And you can see in the controls, they all died within 21 to 25 days. There was a significant survival increase with the TMZ radiotherapy co-treatment, and there was a further moderate survival increase when they further included Indoximod. So this really provided rationale for further pursuing this combination in the clinic. I also want to highlight the fact that we have confirmed these observations in an alternative manuscript that was more primarily focused on CTLA-4 and PD-L1 in adult glioblastoma models, but we can confirm the observations by Dr. Johnson's group as well. And here's where the story gets very interesting. Not all clinical grade IDO1 targeting agents inhibit tryptophan metabolism. Our normal tryptophan levels in human blood are approximately 50 to 100 micromolar. And if we go up to the clinical trials that are associated with Indoximod treatment, we can see the IC50 for IDO1 inhibition or enzyme inhibition is 2.5 millimolar. In contrast, if we go down here to the Incyte compound epacadostat, we can see the IC50 is 7 to 15 nanomolar. And similarly, with the GDC compound that came from New Link Genetics and provided the rights to Genentech, the Pfizer compound has now been pulled because of formulation issues, and the BMS compound, I would make a hypothesis, is going to become the best-in-class IDO1 enzyme inhibitor because it has extremely low nanomolar potency. And so this really raises questions about targeting IDO1, whether or not you're targeting it from an enzyme perspective or from a non-enzyme perspective. So future considerations. I'm not going to re-highlight the data that Dr. Johnson showed, because as we know in the brain tumor community, immunotherapy has failed to provide any survival benefit thus far. And so a question here is, can treatment via radiation, chemotherapy, and Indoximod be further improved for DIPG patients in a safe and effective way? Potentially, once they're through the initial phase 1 and phase 2 clinical trials with the Indoximod radiotherapy and chemotherapy, where do we go from here? Because ultimately, that is our question that we're constantly asking in neuro-oncology. So I do want to highlight some data that we just recently published in Clinical Cancer Research in my laboratory. If we compare dual radiotherapy with an IDO1 enzyme inhibitor, and we fully characterize this enzyme inhibitor, and it's far too exhaustive to include here, what we can see is the dual radiotherapy and IDO1 enzyme inhibitor, it does increase survival here in yellow when we compare it to either the IgG control in blue, the IDO inhibitor alone in orange, and the radiotherapy alone in green. It does increase survival, but not very well. So when we saw this data, we were obviously deeply disappointed, and we asked, what else can we combine whereby it will still be safe and tolerable for glioblastoma patients to receive, but significantly enhance the overall efficacy? And so what we did was we further combined this dual therapeutic approach with PD-1 blockade, because that's always what everyone does these days. And what we found was a very promising overall survival with IDO1 inhibitor, radiotherapy, and PD-1 blockade approach, as you can see in red. One of the reasons we're so excited about this is because IDO inhibitors as a class, whether or not you go to epacadostat, Indoximod, the new BMS compound, is very safe and very tolerable in all phase 1 clinical trials thus far. So it almost makes sense to add in these IDO inhibitors as an adjuvant on top of these other molecular agents. I am also very pleased to state that BMS gave the approval 2 weeks ago to carry out the preclinical study into the clinic as a single site at Northwestern University, and Dr. Remus Lucas is going to be the overall site PI. My laboratory is very privileged to be the primary site for the immunocorrelative studies that will be happening in adult patients with glioblastoma. But I don't think that there's any reason to exclude DIPG as a potential additional tumor type to consider. My time is short, and so I will be very brief. Adult glioblastoma is associated with a median age of 64 years old. In contrast, most of our mouse models that we study, all of our glioma models, are around 6 to 8 weeks of age, which correspond to around a 14 to 16-year-old human being. So we asked a very simple question in our clinical cancer research. If we take the age-analogous mice of an adult glioblastoma patient versus our typical 6 to 8 week old mice and intracranially inject our glioma cells and then we treat, will we see the same overall efficacy? because ultimately we want to translate this into adult glioblastoma patients. The reason I highlight this data here is because the young 6 to 8 week old mice had a significant survival advantage compared to the old 72 to 74 week old mice at the time of treatment. And this also highlights the potential that young patients with pediatric brain tumors may actually respond more favorably to this type of approach compared to adults. So just to summarize very quickly, because I'm out of time, DIPG is very aggressive. Indoximod is an ID1 pathway non-enzyme inhibitory drug that synergizes with chemo and radiotherapy. It's well tolerated in DIPG patients. The median overall survival from this treatment is still pending. And in the future, it might be interesting to determine whether radiotherapy TMZ Indoximod treatment would further synergize with an IDO enzyme inhibitor and or PD-1 blockade. Thank you very much.
Thank you, Dr. Wainwright. We'll move on to our next presentation. This is CT005. The title is FLT3 ligand, CDX301, and stereotactic radiotherapy for advanced non-small cell lung cancer. The presenter is Dr. Ori from Albert Einstein College of Medicine in New York. Dr. Ori.
All right, thank you. Here are relevant disclosures. So as we all know, the interplay between the host immune system and cancer cells has come to the forefront of what we think about when we think about taking care of patients with advanced malignancies. Most of the recently approved agents in the immunomodulatory space focus on unleashing the effector T cells in killing cancer cells. We all know upstream of this, it's critical that there be effective processing and presentation of antigens by cells such as macrophages and dendritic cells. Dr. Chandan Guha was one of the first to realize that ionizing radiotherapy, particularly when combined with immunomodulatory agents, can enhance the ability to effectively perform antigen presentation. In this mirroring study published about 20 years ago, he used a Lewis lung adenocarcinoma model. Mice were implanted with footpad tumors and then received radiotherapy, drug, neither or both. Radiotherapy was a very high dose in a single fraction, 60 gray to the footpad tumor. The study drug was FLT3 ligand, which is a potent mobilizer of dendritic cells, and this was given for 10 days starting the day after radiotherapy. And only in the mice that received both treatments was their observation of induction of primary and memory tumor-specific immune responses, prevention of development of lung metastases, and prolonged overall survival. Other groups in the interim have explored the combination of radiation and FLT3 ligand with less promising results with respect to survival. This perhaps is due to a use of less aggressive radiotherapy schedules. So some background on CDX301 or FLT3 ligand. FLT3 ligand binds a FLT3 receptor to induce proliferation, differentiation, and mobilization of hematopoietic stem cells, early progenitor cells, and both myeloid and plasmacytoid dendritic cells. CDX301 is a soluble recombinant human protein form of FLT3 ligand. This agent has been studied in hundreds of subjects, including healthy volunteers, as well as patients with advanced malignancies. FLT3 ligand has been shown to be extremely well tolerated. It yields 10 to 100 plus fold increases in the dendritic cell population, including the key CD141 positive subpopulation. In a randomized study where FLT3 ligand was added to NY-ESO-1 vaccine in patients with melanoma, FLT3 ligand was demonstrated to augment the humoral and T cell responses. But importantly, as a single agent in patients with advanced cancer, there's really no efficacy signal that FLT3 ligand as monotherapy has clinical activity. So the hypothesis for the clinical trial we're presenting is essentially carrying forward Dr. Guha's work in the laboratory. We believe that the combination of stereotactic body radiotherapy to a single lung lesion, along with FLT3 ligand, will have clinical activity in patients with advanced non-small cell lung cancer. The hypothesis is that radiotherapy, given in a focal and ablative manner, will induce immunogenic cell death, and when given in conjunction with CDX301 or FLT3 ligand, will promote dendritic cell activation and maturation. We hope this will lead to a systemic immune response, where we expect to see that the lesion targeted with radiotherapy will improve. But we also hope to observe improvement in lesions that are not irradiated, the quote-unquote abscopal effect. Here are the study eligibility criteria. These are patients with advanced, incurable non-small cell lung cancer. They must have received at least one standard systemic therapy regimen for advanced disease. Study subjects need to have measurable disease, including one pulmonary lesion that would be suitable for treatment with SBRT, as well as at least one other lesion that could be followed for clinical response. Performance status 0 to 2 is allowed. Patients must not have active untreated CNS disease. Then they should not have immunosuppression or autoimmune disease. Here's the study design. One important factor compared to many of the other regimens out there, this is a short treatment course of just 1 week. In that 1 week, subjects receive daily subcutaneous injections of CDX301. This regimen has been shown in other studies to be very similar in effectiveness to a 10-day regimen that was used in the mouse study. During that week, subjects also receive stereotactic body radiotherapy to a single pulmonary lesion. The doses and fractionation depend on the size and location of the lesion. Peripheral small tumors are treated with a single fraction of 34 gray. Larger peripheral tumors are treated with 18 gray times 3 fractions for a total of 54 gray. And other lesions, such as central lung tumors, are treated with 10 gray times 5 fractions for a dose of 50 gray. For the radiation oncologists out there and anyone else, this may seem familiar because this is taken exactly from the NCCN guidelines for how we treat patients with stage 1 inoperable lung cancer. The intended sample size is 29 patients. You can see the calendar of events in the table at the bottom. Of note, subjects undergo PET-CT scan at baseline and then every 8 weeks. And a little bit of a note of the timing of doing the radiation and the FLT3 ligand concurrently. We know from other studies that FLT3 ligand will lead to a peak in dendritic cells in the circulation about 2 weeks after initiation of study therapy. This also seems to coincide with when we believe tumor antigens will be most disseminated by the radiation. And another important thing to highlight, this is a 1-week treatment course, and subjects in this study do not get any additional anti-cancer treatment at all unless there is disease progression observed. So the primary study endpoint is progression-free survival at 4 months after treatment initiation. This is scored using the CT imaging, using the immune-related response criteria. The null hypothesis, based on some older second-line chemotherapy data, was that this rate would be less than 20%, and we hypothesize with our study regimen it'll be over 40.5%. Secondary endpoints include adverse events, overall survival, and radiographic responses, considering only the lesions that were not targeted with radiotherapy. We're assessing these both at CT using immune-related response criteria, but also with PET scans using PERSIST criteria. The metric that we're interested in with the PET scans is called total glycolytic activity. This is a volumetric sum of all the activity in all the hypermetabolic lesions, again excluding the SBRT target. And the PERSIST guidelines deem that a reduction in TGA of at least 45% is classified as a partial metabolic response. Here are the patient characteristics for the 9 subjects who were enrolled in the year before this abstract was submitted. The table is on the right clearly. I just want to point out a few things. 8 out of 9 patients had at least 2 prior lines of systemic therapy. Most patients had performance status of 2. Among the patients with previous systemic therapy, 7 out of 9 were previously treated with immune checkpoint blockade. 5 of those 7 had been documented to have progression on immunotherapy. And the median interval from discontinuation of the immunotherapy to enrolling on our study was 3 months. Due to the location of the tumors we were targeting, 7 out of 9 subjects were treated with 5 fractions. Here are the adverse events. Study therapy has been extremely well tolerated with no dose-limiting toxicities, which we defined as grade 3 or higher adverse events occurring within a month after study treatment. There was actually one case of delayed pneumonitis. After multiple discussions, this was deemed to most likely be related to prior immunotherapy, as actually the pneumonitis occurred most prominently in the lung that was not treated with radiotherapy. Here's some data from the laboratory indicating that, as one might expect, the FLT3 ligand expands the monocyte population, as well as the myeloid and plasmacytoid dendritic cell subsets, peaking at around 2 weeks. This is very much consistent with what's been seen with this study drug in other studies, but this is the first time that's been demonstrated that this is maintained in conjunction with radiotherapy. Here are the clinical outcomes. So the primary study endpoint was PFS at 4 months. This has been achieved so far in 5 out of 9 subjects. And again, this is using the CT criteria. 6 subjects out of 9 are currently alive with a median follow-up of over 10 months. And clearly, as you can see from the overall survival curve on the right, we have not yet reached median survival. Here are the best responses scored using either CT or PET. And again, this is excluding the SBRT target lesion, which we would expect would respond. Using CT criteria, we've observed 3 partial responses, but with PET, we observed 5 partial responses. Of note, all 5 of those responses with PET were observed on that first PET scan, just 8 weeks after study treatment. The concordance statistics comparing CT and PET indicated a moderate to good agreement. We're going to focus on PET because, as I just mentioned, the responses seem to be seen early on and more robustly. So the 5 subjects with the partial metabolic response, you can see happened kind of right away. Interestingly, if we split it up by subjects who had previously received immunotherapy, all 5 subjects with that partial metabolic response had previously received anti-PD-1 or anti-PD-L1 therapy. Both subjects who immediately had disease progression, those were the 2 subjects who had not previously received immunotherapy. I'll just give a couple of examples. This is the second patient we enrolled. She had a relatively large right central lung tumor as well as several smaller left lung nodules. She was previously treated with first-line chemotherapy and developed progressive disease. She also received 2 infusions of nivolumab, but that was discontinued due to severe arthralgias. So she came to us about 5 months after discontinuation of nivolumab. And looking at this picture, we elected to target not the bigger right lung tumor, but instead the smaller left lung tumor with the highest and most aggressive radiotherapy schedule among our options, which was 34 grade times 1. And of course, we're following the other smaller lung nodules as well as the right lung tumor for quote-unquote abscopal response. And at week 8, we had very promising findings. Clearly, the tumor that we treated with radiotherapy had a good response, but also the contralateral tumor that did not receive radiotherapy demonstrated significant reduction in size and activity. We continue to follow this patient, and she did develop progressive disease at 6 months, but notably that was really interval growth of tumors in the left lung with still good control of the right lung tumor. And she declined further therapy, but we've continued to follow her clinically and with PET scans, and she's clinically quite stable, doing well, and actually on her most recent PET scan seems to have very little evidence of active disease, with, again, no further therapy over about 1.5 years. One more patient example. This is an 80-year-old female with the squamous cell carcinoma of the right lung. She also had bone metastases involving the spine and pelvis. She received first-line chemotherapy, initially had stable disease and then progressed. She then went on to second-line nivolumab, and she received a longer course of immunotherapy, actually about 1 year, initially with partial response, but then with progressive disease, both in the bones and the lung. Nivolumab was discontinued in December 2016, and then the patient came onto our study a few months later. This time we targeted the larger right lung tumor, and because of the location, had to use 10 gray times 5 fractions. And we were following the osseous lesions, most notably in the pelvis, for an abscopal response. At week 8, we see that again that the SBRT target seems to have improved, but more notably perhaps there's been an improvement in the size and activity of the hypermetabolic lesions in the pelvis. We've continued to follow her for a long time now, and she also unfortunately developed progressive disease. This time the progressive disease was in the right lung, basically the same lesion that we had treated with our 5 fractions of radiation. But what's also quite notable is that she's had no progression elsewhere. All of the bone lesions are still controlled. And she just recently was started on salvage immunotherapy, this time with pembrolizumab. So here's something that we're noticing is, again, that this first PET scan after treatment may be a good surrogate endpoint for long-term overall survival. Here's patients divided out by initial partial metabolic response versus no partial metabolic response. And there does seem to be some signal there, although with our limited sample size, not yet statistically significant. So to begin to conclude, we're quite happy that we've been able to finally really form a bench-to-bedside story, taking Dr. Guha's work in the lab and bringing it to the clinic. And we've demonstrated the promise of using ablative radiotherapy and FLT3 ligand to generate an in situ vaccine. Certainly we found this combination is very well tolerated in patients with advanced pre-treated lung cancer, most of whom are elderly and have poor performance status. And we've demonstrated that there is clinical activity with abscopal effects in advanced non-small cell lung cancer, and the responses can be seen relatively quickly, and they, in some cases, have been quite durable. There's a suggestion, at least, that perhaps this treatment combination could be particularly appealing for patients who have previously been treated with immune checkpoint blockade, and including patients who have been treated with immunotherapy and progressed on those treatments. We have a signal that short-term PET scan may give a nice surrogate endpoint for long-term overall survival. And of course, the study continues to enroll to further characterize both the safety and efficacy of this treatment regimen. So for future directions, we're certainly looking to optimize this treatment regimen. There's a possibility of adding booster doses of SBRT and FLT3 ligand as a way to make the response more durable. There's also a possibility of adding an anti-CD40 antibody. This is something Dr. Guha has demonstrated in the lab. Can even make this regimen more effective. These drugs would be expected to enhance dendritic cell maturation and activity in conjunction with radiation and FLT3 ligand. And there's currently an agent that's undergoing testing in phase 1 studies. And finally, of course, we would like to move this treatment regimen further up, perhaps exploring combinations with anti-PD-1 or PD-L1 agents, perhaps using a sandwich approach where our study regimen could be implemented between infusions of immunotherapy. Thank you.
Thank you, Dr. Ori. I'd like now to invite Dr. Sylvia Formenti from the Weill Cornell Medical College to discuss this interesting abstract.
Thank you. Thank you for offering me the opportunity to discuss this very promising work. So these are my disclosures, and I will discuss the off-label use of GM-CSF, sagarmastin, or leucan. So FLT3 ligand is a very interesting agent to combine with radiotherapy to try to convert the tumor into an in situ vaccine. And in fact, it could play a really very useful role in increasing the number, the mobilization, as well as the differentiation of dendritic cells, who are key elements for cross-presentation in the course of the pro-immunogenic effect of radiation therapy. So we also are very sensitive to FLT3 ligand because it was the first compound we used for this proof of principle small mouse trial that first connected the abscopal effect of radiotherapy with an immune-mediated mechanism. And this is in a syngeneic mouse model where we just created two concurrent nodules to try to mimic the setting of metastatic disease in patients. And we radiated one nodule and followed the other nodule as a detector of the so-called abscopal effect. And as you can see from the plots on the right, compared to FLT3 ligand alone that had no effect on either of the nodules, radiation to the primary nodule, of course, had an effect in the field, but not on the other nodule. But when you combine the two, you started seeing effect of field of radiation, an abscopal effect. Importantly, this effect was abrogated in nude mice, and if you implanted a different tumor as a non-irradiated nodule, you could not see the effect either, suggesting that somehow cross-presentation of epitopes from the irradiated tumor were necessary to abrogate a similar tumor on the other side. We then brought it very soon to a clinical trial where we use a palliative dose, a much more modest dose than the one described in the previous study, the 3.5 gray times 10 in heavily pretreated patients with metastatic disease of multiple primary sites. And we didn't have access to FLT3 ligand, so we used GM-CSF, which is less good of a drug for this purpose. We treated, for instance, a patient like this one, where you can see, we will, see if I can get there, yeah. We will treat like a lesion like this and follow behind the block of the field of radiation, a lesion outside the field, this lesion up here, which is not treated by radiation. And in the presence of GM-CSF, we're able to show disappearance of this lesion. And approximately in 1 out of 4 patients treated in this trial, we could see an abscopal response. We also noticed that the patients who had either stable disease or an abscopal response tended to have a low neutrophils to lymphocyte ratio, which is probably a marker the investigators of the study before could also explore in their study. So how to study abscopal responses? If you have an agent that has a baseline activity, an immunotherapy agent that has a baseline activity, you need to really run a prospective randomized trial whereby you can dissect the contribution of radiotherapy to the baseline activity of the immunotherapy tested. However, if you have an immunotherapy that doesn't have proven efficacy when used alone, or you can then do a single-arm trial the way the investigator did in this case. And CDX 301 has no clear activity as monotherapy in solid tumors. So this trial was designed with a primary endpoint of progression-free survival at 4 months, and then they were also looking at lesions outside the field to measure the abscopal responses, and looking at, of course, immune-related resist criteria, and this new marker, which is PMR, partial metabolic response, which is a decrease in the total glycolytic activity of at least 45% at 8 weeks. So the way they selected the dose of radiation, as was mentioned before, is based on the criteria for irradiating primary tumors in the lung, whereby you can give much larger single dose for small lesions and far away from the chest wall and not in the center of the chest, compared to larger tumors or other thoracic lesions that are more central and close to the esophagus and great vessels. So based on the position and the type of lesions that they elected to treat, they ended up treating 7 out of 9 patients, probably because they had larger central lesion with 10 gray times 5. Interestingly enough, as was pointed out before, these were patients with really poor prognostic factor. They're pretreated, they had metastatic non-small cell lung cancer, and they had an ECOG performance status of 2, which is like approximately 50% of your time, not being able to work 50% of your time being up and about, but the other 50% napping or dozing off, so not that strong in general. Also very important to notice that this was just 1 week of therapy with a very modest toxicity, and the results were pretty impressive with, despite the small number, this is the initial data, 5 out of 9 patients getting progression-free survival at 4 months. And then also, as you can see, some of the 5 of 9 patients also had this early marker for total glycolytic response, partial glycolytic response. Why I'm putting so much focus on the dose? We did in the preclinical setting, we tested different dose and fractionation in combination with immune checkpoint blockade, and this is work of Claire Van Puy-Box. And in a model, again, of 2 nodules, when we combine 30 gray or 3 times 8 gray to one of the 2 tumors, we couldn't see an abscopal effect in other setting. But when we added anti-CTLA-4, only the fractionated regimen, but not the single-dose regimen, was able to achieve an abscopal effect. A finding we repeated many times. We repeated the experiment many times because it was difficult to convince of ourselves of what was behind. So the mechanism for radiotherapy, one of the mechanisms for radiotherapy to activate the immune system is by induction of type 1 interferon and double-stranded DNA breaks that occur in the nuclei, either through micronuclei formation or through leakage from the nuclear membrane, get to reach the cytoplasm where they're sensed by the CGAS STING pathway, and by these sensors induce type 1 interferon that then trigger the recruitment of dendritic cells, particularly the BAF3 dendritic cells that are crucial for cross-presentation and mounting of an immune response. So what Claire noticed is that there is a dose dependence of both the induction of dsDNA and TREX1 induction, which I'll introduce in a minute. So you can see that 8 gray tend to induce or manifest more double-stranded DNA fragments here visualized by the monoclonal antibody in the cytoplasm. And it's not a question of total dose or ablative dose, it's a question of dose per fraction, because repeating 8 gray times 3 still develops large quantities of the dsDNA. But at least in our setting, it was impossible to detect double-stranded DNA after 20 gray. And that was due to the induction of TREX1, which is an exonuclease that in fact removes the dsDNA and somehow removes the substrate for CGAS string and the induction of type 1 interferon. And you can see here, 8 gray or 8 gray times 3, no induction of TREX1 that is induced after 20 gray or 30 gray in a single fraction. And as a consequence, the dsDNA is not detected in the cytoplasm. So a series of many murine and human cell lines, as well as multiple PDX models, we were able to show that for different tumors, there are different thresholds for the dsDNA induction after ionizing radiation, as well as induction of TREX1. For instance, in this human triple-negative breast cancer, at 15 gray, you start seeing the induction of TREX1, but in this other model, at 10 gray. In general, across the board, it tends to be around 10 gray. So this balance then enables the optimization of dose and fractionation or radiotherapy in combination with immunotherapy. So I just want to say that it may be a coincidence, but 7 of 9 of the patients were treated with 10 gray times 5, and the 6 are currently alive with disease, so it's pretty impressive in this population. And most importantly, without any other treatment, they were able to be kept without progression of their metastatic non-small cell lung cancer for 4 months in almost more than half of the patients. So in my opinion, the study conclusion is that it is possible that the previous PD-1 therapy may have helped the response in these patients, but it also may have helped to keep the dose per fraction below the TREX induction, which is around 10 gray. I think the PET findings are very promising and interesting and should be validated in larger series. And I would say, from my suggestion, is that to amend the study to enable retreatment, since it's so easy to irradiate a new lesion or a lesion that's progressing, or irradiating the lesion that is progressing. And with the promising data, definitely retest the same mechanism again in the same patient, and possibly include more immune monitoring, including low-hanging fruit like NLR, and possibly storing tissue for T-cell repertoire. Thank you very much.
Thank you, Dr. Formente, for a very interesting discussion. So our final abstract to be presented today is by Dr. Modak from Memorial Sloan Kettering Cancer Center, and he'll be presenting intraperitoneal radio-immunotherapy for desmoplastic small round cell tumor, results of a phase 1 study. And as I mentioned before, this is why the pillars are shaped like antibodies in anticipation of this talk.
Thank you very much, and thanks to the AACR for inviting me to talk about an ultra-rare disease, unusual treatment for a very ultra-rare disease, but that may have potential for other more common diseases down the line. Forward. Left click, right.
We're not getting any, can we get some help with the slides, please? Perhaps if you can just say next slide for them, they'll be able to help you.
Here we go. Thank you. These are my disclosures. So since many of you may not know much about this tumor, this is a very rare sarcoma. It's a translocation-driven tumor which arises because of the fusion of chromosomes 11 and 22, which leads to an EWS-WT1 fusion. And as you can see from this CT, these are large masses of tumor which arise from serosal surfaces. 90% of those arise from the peritoneum, and they can invade organs, and essentially this is a disease with a very, very poor prognosis. Disease is almost always disseminated throughout the peritoneum at diagnosis. And when you look under the microscope, you see these small round blue cells which are embedded in a desmoplastic stroma from which this tumor gets its name. And the current status of treatment for a tumor which is thought to have less than 50 new diagnoses per year in the whole of the United States is unclear. But here's what we know. We know that this tumor is very moderately chemosensitive and radiation sensitive. And we and others have used high-dose chemotherapy in the past to reduce the disease burden. We know for sure that the only patients who survive or are long-term survivors require what's called a gross total resection. And here we define gross total resection as about 90% reduction or 90% resection at surgery. We also know that radiation therapy from the external beam radiation therapy is effective in patients in whom gross total resection is achieved. So external beam radiation can further improve survival in patients, only in those patients in whom resection has been achieved. Other investigators have used HIPEC, and HIPEC thus far seems to have only a modest impact on overall and progression-free survival. And we have reported our experience using myeloablative transplant in these patients, again, with very poor results. So before 2009, at which point we started using radioimmunotherapy, our approach was first to do high-dose chemotherapy, either followed by a single surgery or a second-look surgery. And the second-look surgery was sometimes indicated because the first surgery required an ileostomy being placed because of disseminated disease, often disease in the pelvis, and so patients require several surgeries for a gross total resection. And this was followed by whole abdominal radiation therapy. And in some patients, maintenance chemotherapy after that was tried, but that's quite a tall order because patients have received a lot of treatment at this point, and it's difficult to tolerate. So that was our status before 2009, and we hypothesized that this tumor could be considered for targeted radioimmunotherapy, and that's because most patients, almost all our patients at that time would relapse. Their first relapse was within the peritoneum, even after getting surgery and radiation. We thought that this type of treatment could target micrometastasis within the peritoneum. It was a relatively non-cross-resistant modality. Chemotherapy is often not very easily given or does not penetrate the peritoneum very well. But chiefly because we had tested this compartmental therapy using the antibody omburtamab in the past. And antibody omburtamab previously was called 8H9. We've shown previously that it binds to a large, wide variety of pediatric solid tumors. And in this slide, you can see that this is expressed on cell surface on desmoplastic small round cell tumor, GBMs, and rhabdomyosarcoma. The expression of B7H3, the antigen to which omburtamab binds, is on the cell surface. And when you radiolabel omburtamab, we showed that it would target the only DSR-CT cell line. In this slide, you can see a mouse with a flank DSR-CT tumor, which was targeted with radioiodinated 8H9. And when we used large doses of radioactive or radioiodinated 8H9, we could ablate tumors, flank tumors in B7H3 expressing mice, in this case a rhabdomyosarcoma. So this was a summary of the preclinical data for this antibody. And we also have access to a novel positron emitter, iodine-124. And using iodine-124 radioiodinated omburtamab, we can acquire very high-resolution immuno-PET images, and that allows us to do detailed pharmacokinetic assessment of this antibody. And since the last 10 years, we have validated this for compartmental radioimmunotherapy in the CSF compartment and for DIPG tumors in the pons. For patients with CNS diseases, like especially for CNS neuroblastoma, which expresses B7H3, we have established a phase 2 dose of 50 millicuries as a flat dose. We've treated 93 neuroblastoma patients and about 60 non-neuroblastoma patients, all metastatic to the CNS. We can show that it targets to disease in the CNS. And incorporating radioimmunotherapy with intramyomo omburtamab, we have kind of almost radically changed the natural history of patients with CNS neuroblastoma when it was incorporated into a multimodality therapy for CNS relapse. So the historical data for patients who relapse with neuroblastoma in the CNS was uniform fatalities, but when we combine omburtamab radioimmunotherapy with this multimodality regimen, most of our patients are long-term survivors. So this has been a huge change in the management of these patients, and omburtamab recently received breakthrough designation from the FDA for the treatment of this disease. Another compartment, as it were, where we've injected radioimmunotherapy using radioiodinated omburtamab is the pons. And as you can see here, this is a patient with DIPG where radiolabeled antibody can be directly delivered via convection-enhanced delivery. And so far, 33 patients have been treated without MTD being reached. So based on this compartmental radioimmunotherapy, we hypothesized that we could address another compartment, in this case, the peritoneal compartment. And we carried out a phase 1 study of intraperitoneal radioimmunotherapy using I-131 labeled omburtamab and a biodistribution study of I-124 labeled omburtamab in patients with primarily with DSR-CT and also including a few other patients with other B7-H3 expressing tumors. And we wanted to define the toxicity, the maximum tolerated dose, and in addition, we wanted to acquire data on tumor targeting and biodistribution. And patients were required to have the diagnosis of either DSR-CT or other tumors which express the B7-H3 antigen with peritoneal involvement. And initially, for all patients, we mandated that stem cells be harvested because we were concerned that we would create severe myeloablation with a radioiodinated antibody. Patients could not have any dense intraperitoneal adhesions, so typically a patient had definitive surgery to remove intraperitoneal tumor. Surgeon then put these patients through adhesiolysis, and a catheter was placed so that we would get good circulation of the radioiodinated antibody within the abdomen. And this was the standard 3+3 design, and we did imaging on the first 35 or the 44 patients and gathered data on organ dosimetry. So the treatment schema was as follows. Patients had a catheter inserted and laparotomy, then had thyroid blocking agents started. A dosimetric dose was injected into the catheter. We did pharmacokinetics, acquired biodistribution data based on the immuno-PET using this agent. We then injected a therapeutic dose, and then we followed the therapeutic dose with pharmacokinetic information on the blood, and after 24 to 38 days, patients underwent disease evaluation. Although most of our patients who were treated did not actually have evaluable disease, and I'm going to come to that in a bit. So the way the radioiodinated omburtamab was prepared was a standard iodigen method. We had iodine 124 made in our cyclotron at MSKCC. So it was for this tracer diagnostic or biodistribution agent. It was produced in-house. And we've created a pipeline to manufacture radioiodinated omburtamab in external centers for distribution to other centers if required, but that's what was done for our therapeutic dose. We made sure that the antibody is pure before injecting into patients, and we had a standard radioimmunoassay set up, and the antibody was injected into the peritoneum within 6 hours of preparation using a lead-lined pump. So we have treated 44 patients thus far, 41 patients with DSR-CT, and 3 other patients with rhabdomyosarcoma, which express B7-H3 antigen. Typically, from debulking surgery to radioimmunotherapy, there was a median of 18 days. And these outliers are because these were the patients who had had two-stage surgery done, a few patients. These were a very, very high-risk group of patients. Even those patients who have not relapsed have an overall survival, a long-term overall survival of less than 20%. And what's a point to make here is that we were not able to sustain a catheter in 9 additional patients. So besides these 41 patients, we had 9 additional patients who were offered this therapy. But in this group of patients, we could not maintain the patency of the catheter. And this is important because this kind of forms our control group, because they received exactly the same therapy as the patients with IP radioimmunotherapy, and I'm going to come to that in a bit. So this table kind of highlights the challenges of treating patients with a very rare disease. So initially, we started off at 30 millicuries per meter squared. We went up, we were expecting to reach a maximum tolerated dose of 60 millicuries per meter squared. We did not reach that. We then went up to 70 and 80 millicuries per meter squared, and then finally to 90 millicuries per meter squared. We did not see MTD at 90 millicuries per meter squared, but we established a recommended phase 2 dose of 80 millicuries per meter squared, primarily because that allows us to do outpatient radioimmunotherapy. As some of you know, radioimmunotherapy or targeted radiation injected systemically faces a lot of regulatory challenges. And for patients who receive more than 200 to 250 millicuries, they are required to be treated inpatient and monitored very carefully. So we decided upon our recommended phase 2 dose primarily because of our ability to administer this outpatient. This is a treatment which is very well tolerated. We did not encounter any patients who are myeloablated, so we did not need to use any stem cell rescue in our patients, despite these patients being heavily prior treated. We did not see any significant hypothyroidism. All grade 3 and 4 toxicities were transient and resolved without specific treatment. And really the main toxicity was a transient abdominal pain, because after injecting the radio-labeled antibody, we infused about 1.5 liters of saline to allow for uniform distribution, and most patients have some discomfort during that time. So it was a very well-tolerated treatment, and after the first 3 patients, we were able to treat all patients outpatient. And this is the type of imaging we get after doing immuno-PET scans after injecting radioiodinated omburtamab. And you can see that you can draw regions of interest around various organs, and then over time calculate the area under the curve to determine the exposure to various organs. So this is a preliminary analysis on the pharmacokinetics. The mean blood half-time is about 51 hours. The mean whole body clearance time is about 41 hours. So that's quite similar. The doses to the kidney, liver, lung, and spleen were very well tolerated. So for example, the kidney received about 1.3 rads per millicurie, and the maximum millicuries injected were about 200. And the kidney, as we know, has a tolerance of about 1,500. So all the organs received well below toxic levels of radiation. We also found that most of the iodine which was measured in the blood was bound to protein, indicating that the iodine did not fall off the antibody when it enters the systemic circulation. And to our surprise, the immunogenicity of this murine antibody was relatively low. Only 2 patients out of 36 which have been analyzed thus far show a human anti-mouse antibody. And that's probably because of the chemotherapy these patients have received in the past. Now, how do we know this antibody is doing anything or this therapy is doing anything? And this is a difficult question to answer, primarily because this disease is very, very rare. There has been no standard approach to treatment in the past. Historically, progression-free survival has not been established, although now both our data and the MD Anderson data suggest that even the best progression-free survival is a median of about 13 to 14 months. There's no treatment, standardized therapy for relapse. And because we don't expect this treatment to be effective for patients with bulky disease, we cannot measure responses. This therapy is really targeted to eradicate minimal rather than bulky disease. And finally, we don't have a surrogate biomarker which we can follow. Now, having said all this, of our 41 patients treated, we wanted to identify the group of patients in whom we do have data. So patients who had not previously relapsed, who undergo gross total resection and then undergo whole abdominal radiation, we know that this is the best group of patients historically in whom both our data and other groups have published and presented a progression-free survival of about 13 to 14 months. So if we can show that radioimmunotherapy enhances this progression-free survival, one can be more enthusiastic about this therapy. So although there's a lot on this slide, I think this is where we are trying to figure out whether radioimmunotherapy actually helps patients with this best group of patients. So in our study, 20 patients underwent gross total resection, then underwent whole abdominal radiation. And of these 20 patients, only 9 have relapsed thus far. And our median progression-free survival is about 18.5 months. Only 2 of these patients have died. This progression-free survival is statistically significantly better than those patients in whom we had a catheter problem and we could not give intraparenchymal radioimmunotherapy. All of these patients went on to get our standard treatment, and none of these patients have, all of these patients have had progressive disease thus far. So based on this data and our historical data on patients in a similar group who had undergone stem cell transplant, we now feel that there is a signal that radioimmunotherapy improves the progression-free survival for patients with DSRCT. However, for patients who had gross disease or bulky disease, radioimmunotherapy did not seem to have any benefit. So as we kind of expect, this type of disease to eradicate peritoneal micrometastatic disease was ineffective for patients who had bulky disease left behind. Finally, for patients with rhabdomyosarcoma, there were 3 rhabdomyosarcoma patients also treated. All of these were very high-risk patients in whom overall survival was expected to be less than 10%. 2 of them had previously relapsed, and all of them had received radiation therapy in the past. 2 of these patients remain alive without evaluable disease. A 3rd patient, interestingly, had relapsed in the leptomeninges previous to relapsing in the peritoneum. That patient was treated with radio-labeled omburtamab in both compartments, and unfortunately she had a relapse in the ovary, a retroperitoneal structure, and did not relapse at all in the leptomeninges. So there's some idea that maybe this therapy can be used for other B7H3 expressing tumors. There are limitations to treating in our study. We did have problems with the catheter. We could not evaluate disease responses. This was a very heterogeneous group of patients. But we conclude that radioimmunotherapy with iodine-labeled 131 omburtamab was safe. We could administer it outpatient. It had low immunogenicity. We were able to gather quite elegant pharmacokinetic and dosimetry data using our novel PET-emitting isotope. We've established a phase 2 dose. And the group of patients in whom we believe this is most suited for are those patients in whom disease can be debulked, and certainly other diseases such as ovarian carcinoma, which also expresses B7H3, should be considered. So our current approach is now to do chemotherapy, gross total resection, and then insert this cassette of radioimmunotherapy after gross total resection, then follow up patients with whole abdominal radiation. And our phase 2 study is going to aim for a favorable progression-free survival using an established phase 2 dose of 80 millicuries per meter squared to try to push up the PFS to 20 months. We have established a droplet digital PCR to target the translocation associated with DSRCT, and we are now going to use this to monitor disease in the blood and in the peritoneal fluid, and we want to gather further information on its toxicity. And finally, I want to acknowledge this is a very rare disease, very difficult to get funding to treat such patients. I want to acknowledge the 2 foundations who sponsored the initial part of the study, and the sarcoma spore grant. And it needs a lot of people from various disciplines to carry out this study. So I'll stop here. Thank you.
Thank you for that very interesting presentation. Our final presentation in this plenary session will be from Dr. Quinlea Dunse from Roswell Park Cancer Institute, who will discuss the results of this study.
Next slide. Thank you for the opportunity to discuss this paper. I have nothing to disclose. So DSRCT is a very highly aggressive sarcoma subtype, and it usually presents with massive tumor burden as shown in some of those CAT scans that you saw. Current conventional treatment approaches can result in severe side effects. As you can see, these patients get chemotherapy to start with. They get surgery, more chemotherapy, another surgery, radiation, more chemotherapy. So this is pretty aggressive form of treatment that may result in significant side effects, and yet the survival rate is only 15 to 25%. Consequently, the current study leveraging the approach of radio-immunotherapy is important because it leverages some aspects of current standard of care, along with understanding of the biology of the interaction between radiation and immune system. So the antibody in the study targets B7H3, and the question is, why will you target B7H3? B7H3 is a unique immune checkpoint target for cancer immunotherapy. It's expressed in several human malignancies, as listed here, and for the most part, many of these solid tumors express at very high frequencies, up to 60 to 93%. And in many cases, the expression correlates with poor prognosis and clinical outcome. B7H3 is also unique because this pathway regulates not only innate and adaptive immunity, but also has immune-independent properties on cancer cells by mediating migration, invasion, and metastasis. But in several preclinical models, blockade of this pathway results in increased T-cell infiltration. So how exactly does B7H3 function in anti-tumor immunity? If you look at the interaction between the antigen-presenting cell and a T-cell, as many in the audience will know, signal 1 MHC-TCR interaction, along with co-stimulation between CD28 and interaction of CD28 and CD86, results in a positive signal. Interaction of the known, very well characterized immune checkpoints, PD-L1, PD-1, and CTLA-4 results in negative signal. The interaction between B7H3 and its ligand, which is currently not very well defined, generated a lot of controversy over the past 15 years when it was discovered. The initial studies suggested that this interaction leads to co-stimulation, a positive signal to a T cell, but more recent data and more recently the weight of evidence suggests that this is in fact a negative, has a negative effect on T cell proliferation and function. Consequently, if you block this pathway with omburtamab that was presented in this in the abstract, you affect T-cell responses. You can in fact amplify T-cell responses, but importantly, you can do other things, potentially inhibit invasion, migration, and metastasis, and potentially also inhibit angiogenesis. So there are multiple consequences of blocking this pathway that can in fact be used for anti-tumor immunity. I'm not going to spend too much on this slide because it was discussed in one of the previous abstracts, but just to remind us that radiation has a number of consequences on tumor cells to promote their immunogenicity. And some of the key consequences include the release of calreticulin, which then allows dendritic cells to be able to uptake and present antigen better. DNA that is released by dying cells also activate the STING system that leads to production of interferon, the release of HMGB1 that activates TLR4 on dendritic cells and also enhances cross-presentation by dendritic cells. ATP, so all of these signals are positive for dendritic cells and endow dendritic cells with better ability to cross-present antigens and generate CTLs that then destroy tumor. There are a number of negative immunosuppressive signals that radiation can induce, such as TGF-beta and CSF, and this needs to be taken into account as we consider this whole area of radio-immunotherapy. So the study that was presented has a number of strengths. Number one, this is one of the studies that is targeting an immune checkpoint beyond PD-1, PD-L1, and CTLA-4. At many of these meetings, we hear a lot about this conventional immune checkpoint. There is strong scientific premise. It's expressed in more than 95% of DSRCT. Again, this is a very aggressive sarcoma. It's an unmet clinical need. Another strength is that the investigators went on to develop and validate in the neuroblastoma human system the use of this blocking antibody. There was detailed presentation of the PK, dosimetry, and biodistribution, and it's an uncomplicated 3+3 simple phase 1 study design. The selection of patients was targeted. It was based on expression of the target. 41 patients in total. There was successful dose escalation to 80 to 90 millicurie, as shown in the presentation. And now the investigators have been able to select a phase 2 dose. This treatment seems to be tolerable. There were no DLTs. MTD was not reached. And outpatient administration was possible, and there was no need for stem cell rescue. The PK dose for the delivery has also been identified, and this appears to be a dose that is tolerable by many of the patients. So in terms of preliminary evidence of efficacy, it appears as if signal of efficacy is limited to those patients in the best prognostic category. These are patients who may well have a different tumor biology because they're able to undergo gross tumor resection, whereby you have complete resection of all visible tumor as much as possible, followed by whole abdominal irradiation in this group of patients. So these patients had a median PFS of 18.5 months compared with historical controls that is usually about 13 months, and the overall survival seems to be highly improved. So the approach at MSKCC based on the radio-immunotherapy program has actually allowed this institution to introduce IP radioimmunotherapy following the gross total resection. This is a switch from how it had been done in the clinical trial, where in fact the IP radioimmunotherapy was delivered after the abdominopelvic radiation. But currently this is the approach, and I think this is the approach that has been taken to the phase 2 trial. So clearly there is signal of efficacy. This is a treatment that is well tolerated, but a number of considerations for the authors. Number one, PK measurements of the B7H3 antibody perhaps would be important for us to understand because although we see the biodistribution very nicely demonstrated, it would be important to also understand how the antibody is the levels of the antibody, not only in the peritoneal cavity, but outside of the peritoneal cavity. The other piece of data that I think will be important going forward is to understand how the treatment actually modulates the tumor microenvironment. What is the impact of the radiation on immunogenic cell death, T-cell infiltration, MDSCs, angiogenesis, and other factors that can be affected by B7H3 pathway. Then in terms of the sequence of radioimmunotherapy with whole abdomen radiation, is how critical is this? Because now going forward in the phase 2 trial, the investigators are switching from what they've been doing before. How important is this switch in terms of the sequence of RIT with whole abdomen radiation? And in fact, in order to reduce toxicity, can we completely omit whole abdomen radiation? And finally, I would just like to congratulate the authors. This must be a very difficult study to pull together with all the regulatory components of delivering radiation intraperitoneally. Thank you.
Thank you, Kunle, and thank you to all the speakers and to the discussants and to the audience. This concludes this afternoon's plenary session.
Okay, good afternoon. Can everybody hear me? Can you hear me at the back? Yes, good. No? So we have, this is the precision medicine session. As they say on the airplane, if you aren't interested in precision medicine, this is not your session. We are going to start with this first speaker, who's Dr. Vivek Subbiah, who is at MD Anderson Cancer Center and is going to talk about his work with RET-directed targeted therapies.
Good afternoon, everyone. On behalf of my co-investigators and the entire research team, it is my honor to present the first results of the ARROW study, which is a first-in-human phase 1 study of highly potent and selective RET drug in RET-altered cancer patients. All right. I have the following research support to conduct clinical trials. In normal cells, the receptor tyrosine kinase RET functions in a ligand-dependent manner to control organ development and homeostasis. Oncogenic RET alterations that include RET activating mutations and the RET fusions are oncogenic and drive tumorigenesis. RET is a rare driver of multiple diverse cancer types. As you can see, it is prevalent in medullary thyroid cancer 60% of the time. It is prevalent in 100% of hereditary medullary thyroid cancer. In papillary thyroid cancer, it is 10 to 20% of the time, and in non-small cell lung cancer, 1 to 2% of the time. And across multiple tumors, it is seen in less than 1% of patients. So patients with RET alterations have not benefited from precision oncology. As you all know, patients with EGFR mutation, ALK fusion, and ROS1 fusion have benefited from the era of precision oncology with the selective inhibitors. Currently, there are non-targeted paradigms for RET. Available therapies that target RET have been repurposed, so-called the dirty multi-TKIs, and were not designed to target RET and often have high toxicity and decreased activity. Blue 667 is a designer drug that was used to treat RET-altered cancers. As you can see, blue shows strong nanomolar potency, sub-nanomolar potency across all oncogenic RET variants that include the RET gatekeeper aberration. In the middle slide, you can see that blue 667, this potent RET inhibitor, is 10,000 times more potent than the currently available repurposed multi-kinase inhibitors, RxDX105, vandatinib, and cabozantinib. In the whole kinome, blue has high selectivity for RET, as you can see it here. This slide shows that blue potently inhibits RET-driven tumor growth. In this slide, you can see that this patient derived xenograft with non-small cell lung cancer, that's KIF5B RET fusion, shows regression, and that is dose-dependent. And you can see the regression and downregulation of RET pathway genes, the dual phosphatase 6 and sprouty mRNAs, which is dose-dependent. So based on all this, the blue arrow first-in-human clinical study was designed. So this is a first-in-human clinical study of advanced RET-altered solid tumors. This was using the Bayesian optimum design. The key objectives included MTD, safety, PK, PD, and anti-tumor activity. We have established the MTD from this dose escalation study. I will be presenting the results from this phase 1 study. And the phase 2 dose expansion is enrolling globally based on this 400 milligram once-a-day dosing. As you all know, it's easy for patients to take once a day of a drug. 53 patients were enrolled, 51 patients were RET-altered. 29 patients had medullary thyroid cancer patients, and 19 patients had non-small cell lung cancer. Patients were heavily pretreated. 51% of patients had prior multikinase inhibitor therapy, and 34% of patients had prior immunotherapy that included vaccines, immune checkpoint inhibitors. Diverse RET genotypes were enrolled. The most common alteration for medullary thyroid cancer was M918T, and the most common alteration for non-small cell lung cancer was KIF5B RET fusion gene. There was a patient with paraganglionoma also enrolled, and the papillary thyroid cancer fusion was CCD6. So based on the Boeing design, the dose was escalated from 30 to 600, and 400 was achieved as a maximum tolerated dose. To date, we have 41 out of 53 patients who remain on study in a phase 1 dose escalation study. This is fantastic for a first-in-human clinical trial. As you can see, the PK study showed dose-dependent exposure of RET pathway inhibition, and the half-life is over 12 hours, supporting the Q-day dosing. On the right side, you can see pre- and post-biopsies of tumor pharmacodynamics showing the RET pathway gene alteration, again showing dose-dependent decrease of the dual phosphatase 6 and Sprouty4 mRNAs. This slide shows dose-dependent decline in medullary thyroid cancer tumor markers, namely the carcinoembryonic antigen and the calcitonin. Again, this is what wakes an investigator up in the morning, a phase 1 investigator up in the morning. This is one of my patients who was a 27-year-old young adult male who had a massive neck mass that they had to do tracheostomy and emergent surgery. So given the tracheal invasion, esophageal invasion, and the involvement of blood vessels, the multidisciplinary consensus was against radiation therapy. The current FDA-approved drugs, namely cabozantinib and vandatinib, were not advised given the VEGF2 toxicity, meaning hemorrhage fistula formation. So this patient was one of the first patients who came on the Blue 667 study. Seeing the preclinical structure, having high potent against the RET target, we enrolled the patient on a low dose at 60 milligrams. Quickly, he had a reduction in calcitonin. He started feeling better, and we slowly dose escalated him from 60 to 100 to 200 to 300. Right now, he's almost a year out, and he's at the MTD 400 milligrams, and he's doing really well, working full time. This is a young lady, again, a 37-year-old young female with non-small cell lung cancer, a mom with a family, and her FISH showed RET gene rearrangement, and you can see the ctDNA results showing the KIF5B RET fusion. Immediately, we started seeing, you can see in this panel, reduction of the ctDNA. And currently, she's continuing for 8 months on therapy. This is a 74-year-old man. So this patient progressed on 2 lines of chemotherapy, radiation therapy. Next-gen sequencing revealed RET KIF5B fusion, and he was enrolled on the investigator-initiated vandatinib and everolimus clinical trial. He had a response, partial response. He continued for 11 cycles. Unfortunately, he had a massive progression. When he presented at progression, his PS was declining, and he was wheelchair-bound. He entered Blue 667 study. Within a month, he was up from the wheelchair and started walking. And this was fantastic. And his wife says that he was never able to walk in the Atlanta airport ever. And only after this drug, he has started to walk in the entire Atlanta airport. So this was fantastic for a phase 1 study. Again, thanks to Justin and Jessica Lin from MGH, who shared the rapid inhibition of RET KIF5B mutation lung cancer in the brain. And this shows rapid activity against non-small cell lung cancer brain mets, which is important for RET aberrant lung cancer. This slide shows that Blue 667 has broad anti-tumor activity against RET-altered cancers, regardless of the tumor type, regardless of the genotype, regardless of prior therapies, regardless of the number of prior therapies, and this is fantastic for a phase 1 study. This slide shows a swim plot that Blue 667 has high activity and high response rate in RET-altered non-small cell lung cancer. The overall response rate for non-small cell lung cancer is 50%. This shows Blue 667 has durable and high response rate in RET-altered MTC. I can clearly recognize some of the patients here. The 27-year-old young adult male is the first patient, the red bar. And this is another patient who came on recently. This patient has the resistance gatekeeper germline mutation. After starting the study, he was a different man completely. So we are eagerly waiting for the restaging scans. His calcitonin has dramatically declined. He was having 10 to 20 bowel movements a day, and now he complains of constipation. So we had to report it as a grade 1 adverse event for this study. And he's a different person. Coming to the safety and toxicity of this drug. You can see here, we did not see any grade 4 or grade 5 adverse events. As I said, the central company might be still mad at me because I'm reporting constipation. As you know, medullary thyroid cancer patients with calcitonin syndrome have 10 to 12 bowel movements a day. So constipation is one of the grade 1 side effects. Most adverse events were grade 1. 16% had grade 3 treatment-related adverse events. And this is very, very reasonable for a first-in-human study. In conclusion, blue delivers. Potent RET pathway inhibition, preclinically and clinically. Broad anti-tumor activity regardless of RET genotype, regarding of the indication, and regarding of prior therapy. It shows high preliminary response rates and durable activity for a phase 1 dose escalation study. You see that patients came in at lower dose levels. And even in this phase 1 study, the RET fusion non-small cell lung cancer overall response rate is 50%. The RET mutant medullary thyroid cancer patient, the response rate is 40%. Among all the RET fusions and mutations, non-small cell lung cancer, medullary thyroid cancer, and PTC, the overall response rate is 45%. 41 out of 51 of the RET-altered patients remain on study as of this date. The ARROW study this time has clearly hit this target. This is a dose escalation study, and it validates that this potent RET inhibitor is promising for RET-altered cancers. The expansion phase is open and enrolling globally. The foundational preclinical work that includes the molecular structure of the drug and all the work that went there, and the clinical translation, including the patients some of the patients that were featured in the presentation, have been published today in the AACR journal, Cancer Discovery. In conclusion, I'd like to thank all the motivated patients, their supporting families, all the terrific co-investigators, many of them are sitting here, and all the fantastic research coordinators at all the following institutions. Thank you. Thank you.
Do you want to have a seat?
Absolutely.
And we'll have the discussant come up. So I think we can see that it's a new age for phase 1 studies. I still remember where we could do every phase 1 study. You would be lucky if you had a response on it. We're going to have Alexandra Drilon, who is the clinical director of early drug development at Memorial Sloan Kettering, discuss this study.
All right. Thank you to the organizers for the invitation to discuss this exciting data, and congratulations to the Blue 667 investigators. My title for this talk is More Selective RET Inhibition for Cancers with RET Alterations. Should older drugs retire? Let's see if my slides will advance. All right. Perfect. Thank you, Vivek. So these are my disclosures. All right. So you've heard from Dr. Subbiah that several genomic or genetic alterations can activate RET in cancer. On the left, you have recurrent gene rearrangements or RET fusions. And on the right, you have RET mutations, either in the extracellular domain or in the kinase domain. And we've known about RET as an oncogene for more than 30 years now. However, the sobering fact is that to date, there is no targeted therapy that's yet approved for a molecularly defined population of RET-altered cancers. And so I think it's worth a short trip through history to understand why this is the case. And we are going to begin with the fact that previously available drugs were dirty. As you can see here in this heat map of IC50s, the vast majority of these drugs are multi-kinase agents. You see highlighted in purple that there are many non-RET targets, so there's a lot of off-target activity. You've heard that most of these drugs do have very potent KDR or anti-VEGFR2 activity. And so while these agents have biochemical activity against wild-type RET and RET alterations, they really were not specifically designed to optimally target RET. And we're seeing multiple cases of swift repositioning. Because of that, these drugs are pharmacokinetically limited. And you'll see here that at the FDA-approved doses of many of these agents, including cabo and vandetanib, which are approved for medullary thyroid cancers, at best you're getting approximately 50% inhibition of target when you look at plasma exposures in patients. And so it will come as no surprise to you that the activity of targeted therapy with prior agents is relatively modest. And so we're going to use lung cancer as a paradigm, given that these tumors are enriched for several different drivers. And in this bubble plot, you'll see that when you compare PFS in the y-axis to objective response rate in the x-axis, that the activity in yellow for RET is less than we expect to see for ALK, ROS1, and EGFR. Fortunately, last year, there were two TKIs that were more selective for RET that entered phase 1 clinical testing. You've heard about Blue 667 today and Loxo 292, which was previously presented. As opposed to prior drugs which were repurposed to focus on RET inhibition, these new agents were rationally designed or selected to much more optimally inhibit RET and target RET alterations. And as you can see from the kinome tree on the right, take my word for it, this is much cleaner than many prior drugs. So going now to the data. We're going to first show you the waterfall plot. And I would like to applaud the investigators for carefully molecularly characterizing many of these tumors, as you can see here on the top. This is a waterfall plot that shows us that this drug is active both in lung and thyroid cancers. And also we're seeing responses both in TKI naive and multi-kinase inhibitor pre-treated patients, which is encouraging because many patients are currently on these drugs. As I mentioned again, cabo and vandetanib are FDA approved. Many lung cancer patients are clinical trials. So I think one important thing to hopefully see is that hopefully we can use these trials as a platform to understand resistance to prior multi-kinase inhibitor therapy. Are we seeing suboptimal target inhibition, off-target resistance, on-target resistance? And therefore, molecular characterization will be key. In addition, we need to understand response to prior therapy, and hopefully in the future, see the difference between overall response rate between TKI naive and refractory patients. Another reassuring fact, as you saw, is that there was at least one patient in the Blue 667 set where intracranial activity was observed. And as you can see in the steady state PK plots, that at the dose of 400 milligrams daily, the MTD, plasma exposures did exceed the projected target RET inhibition in the brain, specifically the IC90. But this, of course, is an N of 1, and we hope to see in the future a confirmed intracranial response rate in more patients. How durable is CNS control? What's the profile of CNS progression? And for lung cancers, is this drug active in leptomeningeal disease? However, based on what we know today, reasonable conclusions are that one, more selective RET inhibition is active in a subset of patients with RET mutant or RET and RET rearranged cancers. And second, that the off-target activity of prior multi-kinase inhibitors, specifically very potent anti-angiogenic activity, looks like that's not required to induce a response in select patients, giving us more confidence in these drivers as true drivers, really, of oncogenesis. I think it's fair, though, to take a step back and examine really the confirmed response rate So as you'll note in the tables here below, there were several patients whose responses were unconfirmed. And so I did a little bit of the math here, and that you see when you just pulled out the confirmed response rate for RET-rearranged lung cancers, that's 36%, and for RET mutant thyroid cancers, that's 24%. As you can see, not very different from the activity that we've seen with multi-kinase agents based on the seminal phase 2 and phase 3 trials. Moving on to safety, as we know, older drugs can have substantial toxicity, and what happens with off or non-RET target inhibition is that you can see hypertension, proteinuria, skin and hair changes, rash, and diarrhea that can really impact tolerability and dosing. Thankfully, in this data set, we are seeing that BLU-667 is more tolerable with only 16% grade 3 AEs, no treatment-related grade 4 or 5 AEs. And if you pull out the treatment-emergent AEs and compare them to prior treatment-related AEs, even by doing that, you'll see that there's less diarrhea, there was no reported rash, there was less liver dysfunction. So another conclusion we can make is that more selective RET inhibition can result in lower rates of overall toxicity in patients. However, I think we need to drill down a little bit more also and examine some of the safety data. It is surprising to see tumor lysis syndrome, especially in the solid tumor world. Reassuring that it was found in 1 out of 49 patients in the safety data set, but it's something that we should watch for very closely. On the flip side of the coin, obviously, it's a possible indicator of the exquisite sensitivity of certain tumors to more selective RET inhibition. And the last thing that really struck me is that I was hoping not to see hypertension with this class of agents, but here we're seeing DLTs of hypertension that's grade 3, in addition to other side effects such as hyperphosphatemia and grade 3 lowering of blood counts. Now, what does this tell us? I think it's telling us that if you call back that kinome tree, as you can see, RET isn't the only target for BLU-667, and this drug is not completely RET selective. Some of these emergent AEs may be secondary to the inhibition of other targets like JAK1 or 2 or TRAC-C even. So additional questions that we'd hope to see with mature data. What happened to some of the other patients? So there were 53 that were enrolled, 49 that made it into the safety population. We wonder if those 4 patients were dosed or not. And then of the 49, only 40 made it into the response evaluable population. So I think it's important to understand what the histologies were, molecular features, and the course on trial to get a better feel for this data set. And then finally, there were primary progressors, as you can see here, lung cancer case that didn't respond. In addition to that, I think we need to understand cases where the activity may have been suboptimal. So were there concurrent genomic alterations, suboptimal plasma exposures, false positive diagnostic tests? But what's the verdict? And that's what you're here for. And this is a nod to my youth. I'm dating myself. In terms of response rate, confirmed response rate, based on what we know today, I think that it's a tie between BLU-667 and multi-kinase inhibitors. We obviously do not have PFS data, so stay tuned. The CNS activity, there's an N of 1, so we'd like to see what the larger data set shows. But hands down, I think this drug is more tolerable than prior agents. So for the win, I have to give that to BLU-667. Comparable efficacy and a much more tolerable drug overall. So going back to my question in the first slide, should older drugs retire? And my answer is no. However, they probably shouldn't be given first when there's a choice. And when someone is kinase inhibitor naive, there's access to a more selective RET TKI. I think that should be given first. If they're already on a dirtier drug, then we've seen activity with more selective RET inhibition. And with that, thank you for your attention, and congratulations again to the BLU-667 team.
So both of these speakers have been very efficient. We have time for questions if anybody has any questions. Any questions? Okay, I have a couple of questions. So we're now very pleased that we get responses in 40 or 50% of the patients, and that some of them are durable. But maybe our patients want more than that. So what's the next step?
Next
next step is can you hear me? Yeah. So the next step is, this is the phase 1 dose escalation study. We got to the dose, the 400 milligram once a day dosing, so which is convenient for patients. So the global phase 2 study is open, up and enrolling. So any patient with RET alteration, any cancer type is eligible for the study with any number of prior therapies.
But what about how can we get the response rates higher? What are your thoughts there?
Response rates higher is, again, as you know, I'm a major advocate of universal genomic testing at diagnosis. We need to get patients tested for genomic testing at diagnosis. I think if we sequence these patients upfront and hit with these selective drugs harder at the first round, I think we can win this battle. Muhammad Ali and George Foreman, I always compare this analogy. When they fought the boxing match, Rumble in the Jungle, it took 20 times to hit for Muhammad Ali to win it. Cancer should not be like that. We have these patients who come heavily pre-treated, and we are trying to save them. And to save one human life, as you know, is saving the entire world. I think universal genomic testing should be a part of diagnosis in cancer patients. I think we will make more rapid strides if we use genomic testing upfront.
Okay, thank you. Dr. Drelin, any comments there? Any thoughts there?
Well, I think certainly this class of drug is looking to be very promising. I'd hope to see the response rates rise with more patients. Something else to think about in order to hopefully increase durability of response, and again, I hope we see longer PFS, is that since these drugs are more tolerable, they're also good candidates for potential combination therapy, which may have a role in this space.
So one thing I'd like to mention is, as you all know, this is a phase 1 study. This phase 1 study opened a year ago in March 2017. So many of the patients came in at a lower dose level, and we increased the dose level to a higher dose level. So the overall response rates is just one side of the coin. I've seen patients on Cabo, I've seen patients on Vandatinib personally, and some of the patients have progressed on them. The patients say the quality of life is much better on these selective RET drugs. Again, we should not focus on the overall response rates in a phase 1 study. The phase 1 study is for safety and toxicity. It is commendable that we see all these phenomenal responses in phase 1 study, but the real way to compare Vandatinib, Cabozantinib, apples versus apples, is a phase 2 study with a phase 2 study. This is a phase 1 study. So again, we need to take this data as a win so that we can move forwards for RET altered patients. Thank you.
Yeah, I would like to comment there that I do think that the combinations is another way to go. Obviously, we're getting a lot of mileage in complex tumors from single agents, but the tumors have more going on, and I think that's important. Is there any questions out there? So I have one more question. What do you think about fusions versus mutations? It doesn't look like they're much different, but do you have any impression based on the strength or depth of the responses that you see?
I think it's hard to say. We see that the fusion patients fusions are exquisite. For instance, in KIF by BRET, we don't see much co-occurring alterations if it's fusion driven, and that's exclusively drive the tumor. If there is mutation, there are some co-occurring alterations in the mutation data. Again, many of the mutation patients came in at the lower dose level, so we cannot comment much about the fusion versus the mutation response rate. Again, almost all the mutations were seen in medullary thyroid cancer, which is a different disease, and almost all the fusions, except the 2 papillary thyroid cancer patients, were seen in lung cancer. 2 are different diseases, and again, so different biology, different diseases. So we are able to, it's great that, with this ARROW study, we are able to target RET pathway potently with this drug. Again, we will learn a lot from the expansion study.
Dr. Drelin, any comments there?
Yeah, based on this data that we saw and the fact that you're trying to inhibit a wild-type kinase for the fusions, there may be a lower bar, meaning that you might see a higher degree of activity. With the mutations, there may be more variability because, of course, the guess would be that the different mutations would have different behaviors potentially.
Okay, thank you. So we're ready to move on, and I really think that this is a very exciting area, good discussion. So our next speaker is Dr. Alice Shaw, who's a professor of medicine at Harvard Medical School, and she will discuss the efficacy of lorlatinib in patients with advanced ALK-positive non-small cell lung cancer.
Good afternoon. I first wanted to thank AACR and the Scientific Program Committee for giving me the opportunity to present this abstract. As you heard, the focus of my talk today will be the efficacy of the third-generation ALK inhibitor lorlatinib in patients with advanced ALK-positive lung cancer and ALK resistance mutations. Waiting for this to advance. Thank you. Here are my disclosures. So lorlatinib is an oral, reversible, ATP-competitive, macrocyclic tyrosine kinase inhibitor, TKI, targeting ALK and ROS1. We commonly refer to lorlatinib as third generation because it was specifically designed to overcome known ALK resistance mutations, including the gatekeeper L1196M mutation, and it was specifically designed to penetrate the blood-brain barrier. Shown here is a comparison of lorlatinib with the first generation inhibitor crizotinib, highlighting lorlatinib's greater potency against ALK and ROS1, as well as its lower P-glycoprotein efflux as measured by the MDR-BA to AB ratio. In preclinical studies, lorlatinib has been shown to retain activity against all of the known, or most of the known, ALK resistance mutations identified in the clinic. Now, these resistance mutations can be seen after failure of crizotinib, but they are much more commonly seen after failure of a more potent second-generation inhibitor, such as ceritinib, alectinib, or brigatinib, where ALK resistance mutations account for approximately 50% of relapses. Shown here are data from my group evaluating the potency of first, second, and third-generation ALK inhibitors in BAF3 models expressing different ALK resistance mutations. Compared to earlier generations of ALK inhibitors, lorlatinib does appear to exhibit the broadest activity against these ALK resistance mutations, including the ALK G1202R solvent front mutation, which is the most common resistance mutation emerging on second-generation inhibitors. So in the clinic, lorlatinib has recently been tested in a phase 1/2 clinical trial in patients with ALK or ROS1 positive lung cancer. This slide will show a high-level overview of the phase 1/2 study. In the phase 1 portion, we treated 54 patients with escalating doses of lorlatinib to establish safety, dosing, and preliminary anti-tumor activity. We defined the recommended phase 2 dose of lorlatinib to be 100 milligrams daily, and we did note impressive clinical activity in patients with ALK-positive lung cancer, including those who had failed multiple prior ALK TKIs. In the phase 2 portion, 275 patients were enrolled to one of 7 different expansion cohorts defined by ALK, ROS1 status, and prior treatments. For today's talk, I'm going to focus on the previously treated ALK-positive patients who enrolled into expansion cohorts 2 through 5 in the phase 2. And the specific question we'll address is biomarkers of response and resistance to lorlatinib. So the primary objective of the phase 2 study was to establish overall and intracranial anti-tumor activity of lorlatinib. Secondary objectives included other measures of clinical efficacy, safety and tolerability, patient-reported outcomes, and most relevant for this presentation, selected molecular profiling. Molecular profiling was performed on both tumor tissue and circulating tumor DNA, ctDNA, and blood. For all patients enrolled in the phase 2 portion, a mandatory de novo biopsy was required prior to enrollment on lorlatinib. However, if a de novo biopsy could not be performed, we did accept archival tissue. And it's important to note that this archival tissue sample could have been obtained at any point prior to lorlatinib. Often it was a diagnostic specimen and hence much less informative than a de novo biopsy in terms of biomarkers. Now, tumor tissue was profiled using a targeted NGS assay from molecular MD with a lower limit of detection of 2 to 5% allele frequency. For circulating tumor DNA analysis, we collected peripheral blood samples at screening prior to lorlatinib, after 6 weeks on lorlatinib, and at the end of treatment. And for today, we'll focus on the ctDNA samples drawn at screening. ctDNA was analyzed by Guardant using their 73-gene NGS panel. So before turning to the molecular data, the next 4 slides will summarize the overall safety and efficacy results of the phase 2. So shown here are baseline clinical characteristics of the previously treated ALK-positive patients enrolled into expansion cohorts 2 through 5. And here I've grouped the expansion cohorts to highlight 3 clinically relevant subgroups of ALK-positive patients. First, those patients who had failed prior crizotinib, that's expansion cohorts 2 and 3A. Second, those patients who had failed a non-crizotinib TKI, for example, first-line alectinib, that's expansion cohort 3B. And third, those ALK-positive patients who had failed 2 or 3 ALK TKIs, often first and second generation ALK TKIs, and that's expansion cohorts 4 and 5. As you can see here, the clinical characteristics are as expected for an ALK-positive patient population. In particular, there was a high frequency of brain metastases ranging from 44 to 75% across these expansion cohorts. Now, this slide summarizes treatment-related adverse events, AEs, in all of the patients who enrolled in the phase 2, so all expansion cohorts. And as you can see here, most of the AEs were grade 1 or 2, and the most common ones are listed here. The most common grade 3 or 4 AEs were actually laboratory abnormalities, typically elevated cholesterol or elevated triglycerides. 30% of patients had AEs leading to dose delay, 22% had AEs leading to dose reduction, and only 3% of patients had AEs leading to drug discontinuation. So overall, a safe and relatively well-tolerated drug. As shown here is the efficacy of lorlatinib in ALK-positive patients previously treated with crizotinib, so combined expansion cohorts 2 and 3A with 59 patients. And among these 59 crizotinib-resistant patients, the objective response rate was high at 69%, as was the intracranial response rate of 68%. Median PFS had not been reached at the time of data cutoff, but the lower bound of the 95% confidence interval was 12.5 months. Now, these data are very similar to what's been reported with second-generation inhibitors, alectinib or brigatinib, in crizotinib-resistant patients. And it reinforces the notion that most crizotinib-resistant tumors do remain ALK-dependent and responsive to more potent ALK inhibition. Now, shown here is efficacy of lorlatinib in ALK-positive patients previously treated with 1 or more second-generation ALK TKIs. And here, the objective response rate was lower, but still significant at 33 to 39%. The intracranial response rate also significant at 42 to 48%. And median progression-free survival in these patients who had failed a second-generation ALK TKI was in the range of 5.5 to 7 months. So in contrast to the crizotinib-resistant setting, these data suggest that when a patient has failed a second-generation ALK TKI, there are some patients who remain ALK-dependent and responsive to a more potent ALK inhibitor, but there does seem to be a larger fraction of patients who are less responsive to a more potent ALK inhibitor, and these may be ALK-independent patients. So to identify biomarkers that may be predictive of response or non-response to lorlatinib, we analyzed ALK kinase domain mutations in ctDNA and tumor tissue. And shown here is the data for all of the previously treated ALK-positive patients in expansion cohorts 2 through 5. In ctDNA, we identified 45 of 190, or 24% of patients, with 1 or more ALK kinase domain mutations. I should note here that the 139 cases here shown as no mutation does include patients with no detectable ctDNA. In tumor tissue, we identified 21% or 40 of 191 patients harboring one or more ALK mutations. And again, I want to point out that the tumor tissue that was analyzed was a mix of archival and de novo tissue samples. In fact, close to 50% were archival specimens. So I suspect this is likely an underestimate of the true frequency of ALK mutations in previously treated ALK patients. Now, this slide depicts all of the ALK mutations that were identified in ctDNA or tumor tissue. And you can see here in ctDNA, we detected 75 ALK mutations, with the most common being the G1202R solvent front mutation, followed by the gatekeeper 1196M mutation and the F1174 mutation. And a similar distribution of ALK mutations was seen in tumor tissue. Here there are 58 mutations, again, with the most common mutation being the G1202R mutation. Now, to assess concordance between plasma and tumor biopsies, we compared ALK mutations detected in ctDNA versus tumor tissue for each patient. And here I think it makes the most sense to really look at patients who had temporally matched blood and tumor tissue. So that means blood and de novo tumor biopsies. And here we had 69 patients with these paired blood and tumor samples. 59 or close to 60% had identical ALK mutations in blood and tumor. But as you can see here, a significant proportion, 40%, actually had different ALK mutations in blood and tumor. Now, this discordance between blood and tumor is not entirely unexpected, given the potential limitations in single-site biopsies due to tumor heterogeneity, and also the known limitations in ctDNA assays, especially in the setting of low tumor burden or limited tumor shedding. So now, with those caveats in mind, let's turn to correlating efficacy of lorlatinib with ALK mutations. So I'm going to show over the next 4 slides crizotinib-resistant patients. And this first slide here shows best overall response to lorlatinib according to ALK mutation status as assessed in ctDNA. There were 11 of the 58 patients who had a detectable ALK mutation in ctDNA. You can see the response rate was high at 73%. Similarly, among the group of patients who did not have a detectable ALK mutation in ctDNA, the objective response rate was also high, same in fact, at 73%. Thus, both mutation-positive and mutation-negative patients are highly responsive to lorlatinib. Now, similar results were seen when ALK mutations were detected in tumor tissue. Here you can see that the mutation-positive and the mutation-negative patients both had a high response rate of 73 to 74%. Now, shown here is progression-free survival in the crizotinib-resistant patients, again, according to ALK mutation status, and the results were similar when we looked at ALK mutations in ctDNA or tumor tissue. The numbers are still small for the ALK mutation-positive group, but overall, the progression-free survival does seem to be quite comparable between the mutation-positive and the mutation-negative groups. But now let's turn to a more interesting and I would say clinically relevant setting, which is really the patients who have failed a second-generation ALK TKI. So shown here, I've summarized best overall response in these patients who have failed a prior second-generation ALK TKI according to ALK mutation status as assessed by ctDNA. Here we've pooled expansion cohorts 3B, 4, and 5 to give us a total of 132 patients previously treated with a second-generation TKI. You can see that the response rate among those patients with a detectable ALK mutation is high at 62%, but in contrast, among patients without a detectable ALK mutation in ctDNA, the response rate was lower at 31%. Median duration of response was similar in both cases. Thus, in this case, compared to crizotinib resistance, in patients who have failed a second-generation ALK TKI, the presence of an ALK mutation seems to identify patients who are more likely to have perhaps developed on-target or ALK-dependent resistance and hence likely to respond to a more potent and pan-inhibitory compound like lorlatinib. Now, similar results were seen when ALK mutations were detected by tumor tissue, but these aren't identical. So here you see a higher response rate among the ALK mutation subgroup, 66%, as compared to a response rate of 26% in the mutation-negative group. But what was interesting here is that there was a pretty significant difference in duration of response. Median duration of response in the mutation-positive group was 21.5 months, as compared to just 5 months in the mutation-negative group. Now let's turn to progression-free survival according to ALK mutation status. Here you can see when we're looking at ALK mutations according to ctDNA, there was not a big difference in progression-free survival. Median came in at 7.3 months in the mutation-positive group, as compared to 5.6 months, so very similar. However, again, looking by tumor tissue profiling, we see a striking difference in progression-free survival. The patients harboring an ALK mutation in tumor tissue had a longer progression-free survival, median of 11 months, as compared to 5 months. Thus, tumor tissue genotyping, but not plasma genotyping, seems to be able to identify two distinct subgroups of patients with very different progression-free survival and duration of response on lorlatinib. Now, this slide summarizes best overall response by presence or absence of an ALK mutation in either ctDNA or tumor tissue. So here we're pooling the data, and the data is very consistent when we do this. The response rate in post-crizotinib patients is very high, regardless of ALK mutation status, whereas in patients who have failed a second-generation ALK inhibitor, the response rate is higher in those patients harboring an ALK resistance mutation. Now, delving a little bit deeper into specific ALK resistance mutations, here is shown the activity of lorlatinib in patients harboring one of 5 of the most common ALK resistance mutations seen in the clinic. And this is across all previously treated ALK-positive patients in expansion cohorts 2 through 5. You can see that the numbers of patients with each mutation are on the smaller side, but it does seem like these mutations are associated with durable responses. Now, in particular, I wanted to focus on the solvent front ALK G1202R mutation. I mentioned earlier that this is the most common ALK resistance mutation emerging on second-generation inhibitors. Shown here is best response to lorlatinib in patients with G1202R identified in either ctDNA or tumor tissue. And as shown, the response rate is high, close to 60% in this group of G1202R positive patients. And actually, most patients exhibited some degree of tumor shrinkage. So in summary, lorlatinib is a third-generation, highly potent, CNS-penetrant ALK ROS1 TKI with demonstrated safety and efficacy in ALK-positive non-small cell lung cancer. Based on the phase 2 data, lorlatinib was granted FDA breakthrough therapy designation last year and is anticipated to receive FDA approval later this year. Lorlatinib is highly active in patients who failed on prior crizotinib, with a response rate exceeding 70%, regardless of ALK mutation status. Lorlatinib is also active in patients who have failed one or more second-generation ALK TKIs. But in this setting, the response rate with lorlatinib is higher in those patients harboring an ALK mutation compared to those without an ALK mutation. So these findings lead us to conclude that in patients relapsing on a second-generation ALK inhibitor, ALK mutations may serve as a biomarker to identify patients more likely to respond to lorlatinib. These patients' tumors remain ALK-dependent. Now, in the absence of an ALK mutation, patients seem to be less likely to respond to lorlatinib, and this is probably due to the emergence of ALK-independent or off-target mechanisms of resistance. However, I would note that some mutation-negative patients do respond to lorlatinib. The response rate we saw was 26%. And so the absence of an ALK mutation, especially in a ctDNA assay, should not be used to exclude patients from treatment with lorlatinib. Now, further investigations into tissue versus plasma genotyping of ALK mutations are ongoing. For example, the NCI ALK Master Protocol will be incorporating both tissue and plasma genotyping for ALK mutations in patients who have failed a second-generation inhibitor to establish concordance and to prospectively match those patients to next-line TKI-based strategies. In addition, future studies will be focusing on longitudinal profiling of ctDNA and tumor tissue to help define the evolution and heterogeneity of lung cancers throughout the course of treatment with lorlatinib. And these studies will be particularly important at the end of treatment to identify mechanisms of resistance to lorlatinib, which really will be critical to developing the next generation of targeted therapy strategies for ALK-positive patients. So in closing, I'd like to thank all of the patients, their families, their caregivers for participating in this global phase 2 study of lorlatinib. I'd also like to thank all of the lorlatinib investigators and their study staff. And finally, many, many thanks to the lorlatinib study team at Pfizer, particularly Jean-Francois Martini, Lee James, Holger Thurm, and Jill Clancy. Thank you.
Well, thank you for that very nice presentation. And we now have Christine Lovely, who is the co-leader for translational research and interventional oncology at the Vanderbilt Cancer Center, who will discuss that presentation.
Hi, good afternoon. Thank you everyone for being here. Thank you for the opportunity to discuss this exciting trial. There has been tremendous excitement about this drug in the field of ALK-positive lung cancer, and I hope you can see why. These are my disclosures relevant to this presentation. So taking a step back for a moment and just thinking about ALK rearrangements in lung cancer, I think we need to take a historical perspective here to really understand how exciting these results are. So ALK is a receptor tyrosine kinase that's normally expressed in the developing central nervous system. ALK rearrangements are found in about 5% of all of non-small cell lung cancer. ALK fusions, similar to the RET fusions we heard about, contain the entire ALK tyrosine kinase domain fused to multiple different potential binding partners. And look, you can see here on the right-hand side of the screen are the spectrum of different fusion partners that have been found in ALK-positive lung cancer. Multiple studies now have shown over the past 10 years that patients with ALK-positive lung cancer can have tremendous responses to ALK inhibition. This is the current landscape of ALK inhibitors in clinical use. I think, again, considering that ALK was only found as a target in lung cancer in 2007, and now we have 3 distinct generations of inhibitors to treat our patients with, is quite a remarkable success to precision medicine. This trial particularly talks about lorlatinib, which is the 3rd generation inhibitor, as Dr. Shaw mentioned, that was specifically designed to overcome ALK kinase domain resistance mutations and to also have tremendous CNS penetration. So a discussion overview, and to really put this trial in framework of the current context and landscape of ALK-positive lung cancer, I'm going to use this trial as a framework to discuss 3 potential areas of clinical need. First is defining the optimal sequence of ALK-TKI therapy. Second is identifying and overcoming ALK-independent mechanisms of resistance. And third is really this exciting area of the emerging role of the fusion partner in mediating therapeutic responses. So to start with the optimal sequencing of ALK-TKI therapy, again, I'm putting this in the framework of now 10 plus years of ALK-positive lung cancer. If we think about treating patients with a sequence of different ALK inhibitors, there's actually 3 drugs we have FDA approved now for first-line usage. Crizotinib, the first ALK inhibitor that we had, followed by ceritinib and alectinib, 2 second-generation ALK inhibitors. There are also numerous ongoing studies of other second and third-generation ALK inhibitors in the first-line setting as well. When we think about second-line therapy for ALK-positive lung cancer, this is predominantly the data we have in the context of resistance to crizotinib, and this is an important point because this field is rapidly emerging. Right now, we have the majority of data of second-line therapy thinking about the post-crizotinib setting, and several drugs that have been FDA approved in this space, both second and third-generation ALK-TKIs as listed here. A very important point is that these drugs were approved in the second-line space regardless of biomarker. So there is no indication to do biomarker testing to give a patient, for example, second-line alectinib after first-line crizotinib or second-line ceritinib after first-line crizotinib. These drugs are approved in this space regardless of biomarker status. This is a compilation of the numerous studies that have been done for ALK-positive lung cancer. I'm going to gloss over this so we can get to the meat of the discussion. So if we think about now, and as Dr. Shaw pointed out, a very contemporary issue is when we bring these more potent ALK inhibitors to the first-line setting, such as ceritinib or alectinib, what do we do in the second-line setting? And I think this is one of the most important take-home points for the lorlatinib data, is looking at lorlatinib in patients who have relapsed on these potent second-generation inhibitors. And more importantly, can we bring these resistance biomarkers now into the realm of our daily clinical practice? Again, I want to contrast that to the approval of the second-generation inhibitors in this post-crizotinib space where we do not need biomarker testing. So if we think about the resistance mutations that have been described for ALK, as Dr. Shaw pointed out, and this is work from her group, there has been several that have been described. Here is a structure of the ALK kinase domain, and these mutations fall throughout the ALK kinase domain structure. So here's the G12OR solvent front mutation. There's mutations in the alpha-C helix in the activation segment. I think it's remarkable that 75 distinct ALK kinase domain mutations, single nucleotide variants, were found in the lorlatinib study. This poses a very interesting question, not just from a biochemical perspective, but also from a knowledge perspective. How do we educate clinicians about all these different mutations as they arise? So focusing really in on the G1202R, this is the mutation that we think about as being the most recalcitrant of all the mutations, and the one that lorlatinib has the best data against. So summarizing the data for lorlatinib against these mutations, so one, this is the in vitro data, also data from Dr. Shaw's group. Lorlatinib, again, was really designed to have significant potency against these mutations. What I want to point out from these data as well is amongst the second-generation inhibitors, they have all specific vulnerabilities. For example, the alectinib is quite resistant to a mutation at I1171 versus ceritinib, which has potency against this mutation. So that's, again, a challenge as we think about deploying these biomarkers in the clinical setting to really understand which mutations to use in which context. But for lorlatinib, it has potency against all the mutations that have been described. If you look at the data that Dr. Shaw presented, the G1202R mutation was the most frequently detected amongst the patients in the lorlatinib cohort, followed by the gatekeeper mutation and this F1174 mutation, which is also a mutation in hereditary neuroblastoma. And looking at the two cohorts, I think what's quite remarkable here, and what really drives home the point of the need for biomarker stratification, is if we look post-crizotinib, there really is not a difference, plus or minus mutation status. But if we move to that cohort of patients who had received a second-generation ALK inhibitor, now you see that response rates increase in those patients who had a biomarker ALK-positive kinase domain mutation within their tumor or blood. Moving on now to how to identify and overcoming ALK-independent mechanisms of acquired therapeutic resistance. So in this study, almost half of the patients had an ALK kinase domain mutation. Well, that still leaves half of patients who do not have an ALK kinase domain mutation. And what do we know about ALK-independent mechanisms of acquired resistance? This slide is a summation of a lot of data that has been presented. On the left-hand side of the slide is the ALK-dependent mechanisms of resistance. On the right-hand side of the slide is the ALK-independent mechanisms of resistance, some of which have been described: upregulation of EGFR signaling, IGF-1R signaling, amplification of KIT, new fusions like RET or NRG1 in post-LTKI resistant samples, KRAS mutations, MEK mutations, upregulation of SARC, a very complicated landscape that is still very much emerging. If we think about how do we overcome ALK-independent mechanisms of resistance, so one strategy that has been proposed, and there's multiple combination therapy trials ongoing right now, this is data from Trevor Bavona's lab looking at the combination of ceritinib, a second-generation inhibitor, plus trametinib, a MEK inhibitor, with the hypothesis being here that if ALK signals through RAS-MAP kinase, that using a common downstream pathway, such as a MEK inhibitor, may overcome simultaneously multiple pathways that can bypass ALK inhibition. This is data from a cell line. It's a lorlatinib-resistant cell line that's treated with either lorlatinib alone or with trametinib, a MEK inhibitor, or binimetinib, a MEK inhibitor. You can see the MEK inhibitor has very little efficacy as a single agent, but when used in combination, you now get inhibition of cell viability. There's one ongoing trial of ceritinib plus trametinib that's ongoing, and a planned ECOG-ACRIN study of an ALK inhibitor plus a MEK inhibitor that is in the works right now. Just wanted to point out, because we think a lot about, and there's tremendous excitement, of course, about immune checkpoint blockade. So there has been the hypothesis that combining immune checkpoint blockade plus ALK inhibition may be efficacious in patients who relapse, or could even prolong responses in the first-line therapy. I want to point out some recent data and just a word of caution in using immune checkpoint blockade in this context. This is Group E of the Checkmate 370 study. This is a single cohort, first-line trial of nivolumab plus crizotinib in patients with ALK-positive lung cancer. Here, there was 13 patients, of the first 13 patients treated, 5 of 13 actually developed severe hepatic toxicities that ultimately led to the closure of this trial. So word of caution, and we need a lot of work in this space to understand how to deploy immune checkpoint blockade in the context of ALK inhibition. Then finally, and excitingly, is what is the emerging role of the fusion partner mediating therapeutic responses? So there have been a number of different fusion partners which have been described for ALK and ALK-positive lung cancer. You can see here in this network diagram that several of these fusion partners also overlap with other fusion kinases that we think about, ROS1, NTRK, RET, in lung cancer and other cancers. Just some characteristics of the fusion partner which are important. The regulatory unit of the 5' fusion partner dictates the expression of the fusion, so all these fusions are driven off the promoter of the 5' fusion partner. The fusion partners typically contribute on the oligomerization domain, which mediates autoactivation of the fusion kinase. And last but not least, the fusion partner can mediate subcellular localization, which has been shown to be different depending on which fusion partner is present. This is some recent data that was led by Alice Shaw and Ignatius Wu, published in JCO a few months ago. This is the diversity of EML4 ALK fusion variants which can occur in non-small cell lung cancer. So there's multiple EML4 ALK variants determined by the amount of EML4 present within the fusion. What was exciting about this paper is they were able to show by looking at a large cohort of data and samples is that this variant 3 fusion, which is the second most common EML4 ALK fusion, actually had a higher percentage of development of this G1202R mutation. And this is shown here in bar graph representation on the right-hand side. So basically what this data is saying is it's not only enough to know the fusion mutate or the kinase domain mutation that's present in the fusion, but also the fusion partner may be important in dictating responses and resistance. They also looked at these data in terms of progression-free survival with lorlatinib. You can see here the yellow is the variant 3, blue is EML4 ALK variant 1. Small numbers, but really intriguing data when we have to think about parsing down even further to the level of the actual fusion partner. Last but not least, there is a host of other ALK fusion partners that have been described. These is a cellular line data, an isogenic system expressing all the different ALK fusions shown here. And what the take-home message is that when these different fusions, when expressed at the same level, are treated with lorlatinib in this case, you can see quite a different spectrum of responses, suggesting that it's not just ALK that's playing a role in mediating response, but also the fusion partner. So in the last minute, open questions and future directions. We still have a lot of work to do in understanding the optimal sequence of ALK-TKI therapy, really incorporating these biomarkers into our treatment strategies. Dr. Shaw mentioned the NCI ALK Master Protocol, which is ongoing. Please look to that in the future. I think a very important point here is we think about the complexity of these mutations and how do we deploy this information in the clinic and make sure that this information is up to date and current in any clinical setting, I think is a very, very important issue for us to think about. How do we treat resistance to next generation ALK-TKIs not mediated by an ALK kinase domain mutation? This is a very active ongoing area of research. I'd be very curious to know what other alterations occurred in the data set that was just presented. So we saw the ALK kinase domain mutations, but there were actually 73 genes that were tested in blood and hope to see those data soon. And then last but not least, how will these results from lung cancer be translated to other ALK-positive malignancies? And if you think about these, and one of the most exciting aspects of these kinase fusions, like RET, ALK is altered in multiple different tumor types. We're about to hear about one of those different tumor types in a moment. So thank you all and enjoy the meeting.
Well, thank you. I think we have time for one question, if anybody has a question. Okay, I have a question. So any thoughts about how often to do the ctDNA? Or what is your practice?
Well, I think based on the study, we were proposing that ctDNA done at the time after failure of a second-generation ALK-TKI could be very helpful to identify patients who harbor ALK resistance mutations and whose tumors may therefore be more responsive to a more potent and pan-inhibitory drug like lorlatinib. So certainly after someone fails a second-generation ALK TKI, our practice is actually to perform tumor biopsies typically. However, in cases where we can't do a tumor biopsy, then we do use ctDNA.
Dr. Lovely, any comments there?
No, I agree with what Alice said.
Okay, thank you very much. Very nice. The next presentation is by Dr. Patrick Shopsky, who is the head of the Department of General Medical Oncology at the Leuven's Hospital in Belgium, and he will present on the ALK and myofibroblastic tumors.
Thank you so much. These are my disclosures. We are switching gears again and going back to a first-generation agent, crizotinib, which we have explored in a very rare tumor type called inflammatory myofibroblastic tumor. We did this in the context of a multi-tumor basket phase 2 trial called EORTC 90101, which has the acronym CREATE. This study explored the activity of crizotinib in 6 different tumor types driven by either ALK or MET alterations. And today I will share with you the final results of the inflammatory myofibroblastic tumor cohort, which was independent from the other tumor types. Inflammatory myofibroblastic tumor, or IMFT, is a very rare type of sarcoma, so rare that even some sarcoma specialists have never treated one of these tumors. It can occur in children, in adolescents, but also in adult patients, and it is known to have very limited sensitivity to chemotherapy and radiotherapy. There is no drug specifically approved for this indication. Surgery is the mainstay of treatment, but many patients do not qualify for radical surgery. For example, mutilating surgery or amputations are to be avoided in this disease. The disease has a very high rate of local recurrence and invasion, but as compared to other sarcomas, a relatively low rate of distant metastasis. Interestingly, the WHO handbook on sarcoma mentions 6 different synonyms for this disease, highlighting that it's very difficult to distinguish this malignancy from other benign and malignant conditions. ALK plays an important role in this disease because 50% of the IMFTs have some kind of ALK translocation, which results in activation of the tumor process by ligand-independent kinase activation, leading to downstream signaling pathway activation and prolonged tumor cell survival, more migration, more metastasis. So when planning this study several years ago, we had a very strong rationale to explore an ALK inhibitor in this disease. I wanted to share with you a typical morphology of an ALK-positive case treated in our trial, patient number 192. On the left side, you see sarcomatous tissue mixed with a dense inflammatory population of cells, and on the right side, you see the typical diagnostic ALK staining using immunohistochemistry, confirming the diagnosis of this disease. This is an ALK negative case with a similar morphology, but no ALK staining on immunohistochemistry. I don't have to tell this audience what crizotinib is all about after the 2 prior excellent presentations, so I will skip this slide. But I want to mention that in adult patients, this drug is given at a flat dose 2 times daily, and that the pediatric dose was only established in 2013. So our study restricted the entry of patients from the age of 15 onwards before we could amend the trial. Of note, in 2010, Butrinsky and colleagues published 1 single ALK-positive case in the New England Journal of a patient with IMFT ALK-positive responding to this agent, which triggered a lot of interest and a number of case reports in the literature. These are a few design features of this academic study. It was a single-agent, non-randomized, non-comparative, open-label, 2-stage, parallel cohort phase 2 study. We entered ALK-positive and ALK-negative patients in this trial, which were analyzed separately. All centralized procedures in this trial like reference pathology, immunohistochemistry, and FISH were done in my institution. Patients provided written informed consent, and then the sites shipped a tissue block which was non-returnable, allowing us to do a lot of translational work on these tissue samples. Other selection criteria were pretty standard phase 2 selection criteria. Of note, the presence of an ALK alteration was not mandatory to enter the patient in the treatment phase. The starting dose was the same dose as it is used in non-small cell lung cancer. Patient was continued until disease progression or unacceptable toxicity, and activity was assessed using RECIST 1.1, which was done by the local investigators, but we had central review of the responses. Patients were attributed to the ALK positive or ALK negative cohorts based on immunohistochemistry and FISH. 15% of the tumor cells had to be positive either on FISH or immunohistochemistry using commercially available probes and antibodies. Of note, other alterations which can drive inflammatory myofibroblastic tumors, other genetic alterations not captured by these commercially available tests did not classify a tumor as being ALK positive, which means that some patients in the ALK negative cohort might harbor other alterations that may be targeted by the drug that we explored in this trial, crizotinib. The main objective was to study the activity of the drug in this very rare tumor type using RECIST with response confirmation. And this endpoint was chosen because at the time when I wrote this protocol, we had no published data on progression-free survival or progression-free rate or even overall survival data for this very rare tumor type. The statistical design was fully focused on the ALK positive subset of this trial. The ALK negative patients only served as a non-randomized, non-historical, treated internal control. We had a two-stage design in this study, and we wanted to see at least 2 responses among the first 12 ALK positive patients to go to the next step and recruit a total of 35 ALK positive inflammatory myofibroblastic tumors. In that subset of planned 35 ALK positive patients, we wanted to see at least 6 objective responses. As you see here, it took 5 years or more than 5 years and sites in 8 European countries to find a total of 35 patients with a local diagnosis of IMFT. Interestingly, based on centralized reference pathology, only 24 of these patients qualified for the trial. The others had other diagnoses, were misclassified, or our central review pathologist could not confirm the diagnosis of IMFT, illustrating that it's very difficult, even for big academic sites, to come up with the right diagnosis in this tumor type. 20 patients actually entered the treatment phase, and 19 of them were evaluable for the primary endpoint of this trial. Reference pathology was thus a very important part of our trial. I don't want to go through the other diagnosis of the 11 non-confirmed non-IMFT cases in the trial in the interest of time. In most cases, ALK positivity was based on both FISH and immunohistochemistry. In 2 patients with ALK positive disease, only FISH was positive, and in 3 cases, only the immunohistochemistry. Only 1/3 of our trial population was ALK negative. This is a typical FISH showing the atypical cells with gene rearrangement and the split signal in more than 15% of the tumor cells, qualifying patient number 194 as an ALK positive inflammatory myofibroblastic tumor, while, for example, patient 196 here shows no split signal and was defined as ALK negative. We had to discontinue this trial early because of slow accrual. It took us 5 years to find 19 treated and eligible and evaluable patients with ALK positive or ALK negative inflammatory myofibroblastic tumor, purely due to the orphan character of this malignancy. Interestingly though, When we took the decision to discontinue the trial, we had already met our success criteria because we wanted to see 2 responses among the first 12 ALK-positive patients and a minimum of 6 in the total planned subset of 35 ALK-positive patients. So based on these findings, the according committees of EORTC agreed with the pragmatic proposal to stop this trial, otherwise it would have continued until I retire. I don't want to bother you with patient characteristics of this trial, but what is interesting here is that half of them had prior surgery and less than half of them had received prior chemotherapy or other systemic agents, illustrating the unmet need in this disease. There is no active treatment. Only one of these patients had responded earlier to a chemotherapy combination. That was an ALK-positive patient responding to doxorubicin and ifosfamide. Follow-up in this trial is quite long. Dose intensity was high, almost 95%, and only 5 out of 20 patients that we treated required dose modifications. Treatment lasted up to a maximum of 28.3 months, with a median of 7.2 in the ALK-positive subset and 4.1 months in the ALK-negative patients. This is the efficacy summary of this slide. 2 ALK-positive patients had a complete confirmed RECIST 1.1 objective response. 4 patients had a PR confirmed. 5 patients had stable disease, meaning all patients with ALK-positive disease derived clinical benefit. The response rate was 50%, while in ALK-negative patients, the response rate was 14.3%, with only 1 patient having an objective response. The disease control rate here was also high, with 85%. This is the last patient with IMFT that I entered in the trial. On the left side, you see a MRI scan from April 2017 at baseline with a huge tumoral mass, which almost completely disappeared. This is an ALK-positive patient who has shrinkage of his target lesions by 29.7%. He's still on treatment. I saw him last week, and it's very likely that this and other patients still ongoing in this trial may still convert to a partial response, increasing the objective response rate that I'm reporting today. All patients with ALK-positive disease, depicted here in blue, had shrinkage of their target lesions, with 2 complete responses and 4 partial responses, so 6 objective responses in total. The interesting finding is that also patients classified as ALK-negative had shrinkage. 3 out of our patients in that group showed some level of shrinkage of their tumor, and 1, as mentioned before, had an objective response. And I will come back to that later. Crizotinib achieves objective responses in brain metastases, as we have seen here. This is an ALK-negative patient who had a stable disease of his non-CNS lesions, but had a complete remission of the brain metastasis. And I show you a little movie here illustrating that. On the left side, you see the multifocal brain lesions in May 2017, and on the right side, they have all disappeared. The patient is still continuing treatment and has ALK-negative disease according to our criteria. We have very long follow-up already, so I can share with you PFS and reliable OS data for this very rare disease. As you see here, at 1 year, 73% of the patients are without progression in the ALK-positive subset. In terms of overall survival, at 2 years, 81.8% are still surviving, and there seems to be a plateau which occurs somewhere between 6 and 9 months after the start of treatment, where no ALK-positive patient is dying anymore. This depicts nicely the duration of treatment and clinical course of our patients. What is important here is that about half of the patients remained on trial quite long, that the partial responses occur early during treatment, and it takes a while until some of the partial responses, which are depicted here as yellow dots, are converted to a CR, which is depicted with a orange dot. Of note, the black triangles illustrate that 7 patients are still continuing treatment. What are the hypothetical reasons for anti-tumor activity seen in ALK-negative disease, like the brain metastasis that I shared with you? I think it has to do with our inability to diagnose ALK positivity very well using the commercial FISH and IHC probes that we have applied here. If a tumor only has, let's say, 12% ALK positive cells, according to protocol, we had to classify this tumor as being ALK negative. And we know that the used antibodies and probes do not capture all ALK alterations that have been described in individual patients with this disease in the literature, like the classical EML4 ALK or FN1 ALK alterations that have been published more recently. We also know that there are ROS1 alterations. We learned that while performing this study, and also ROS1 can drive this disease. So last minute, actually about 2 weeks ago, we performed an exploratory ROS1 analysis of all our cases. And to make a long story short, none of our patients had a ROS1 alteration. 23 of 24 patients from whom we had tissue were evaluable for this exploratory analysis. The safety and toxicity that we observed in this trial is very similar to data that you are very familiar with from the field of non-small cell lung cancer, so I don't have to bother you with the details here. We had not a single case of treatment-related death during the actual treatment or within 4 weeks of discontinuation. No real surprises here in terms of toxicity. What are the limitations and what is the relevance of this trial in a very rare disease? Unfortunately, we could only perform a non-comparative, non-randomized single-arm study with a very small sample size and even had to discontinue early. But I guess you will agree with me that given the epidemiology of this disease, it is not possible to perform much larger trials in this disease, and a prospective non-randomized trial is likely the best evidence that we can produce in this tumor type. Interestingly, NCCN already recommends since 2012 the use of crizotinib and other ALK inhibitors for treatment of IMFT. That recommendation was based on one single ALK positive case in the literature at that point in time. We are now providing the scientific prospective evidence from 19 IMFT patients in a disease-specific trial for this recommendation. So what are my conclusions? In terms of the epidemiology and diagnostic challenges in this disease, it is an orphan malignancy, as it took 61 months and 13 sites in 8 countries to find 35 patients with this local diagnosis of IMFT. And considering the 30% misclassification rate by the local pathologist, I guess you will agree with me that reference pathology plays an important role for all future trials in this tumor type. About 2/3 of these patients are ALK positive according to the criteria that we used, and there is acceptable concordance between FISH and IHC that we saw in about 2/3 of the patients. Crizotinib undoubtedly has very important and clinically relevant activity in inoperable metastatic IMFT, giving us 50% objective response in this trial, including complete responses and long-lasting disease control. Interestingly, even though we discontinued this trial early, all success criteria in this arm of the trial were met. All ALK-positive patients with IMFT derive benefit from treatment with this ALK inhibitor, and more than 80% are alive at 2 years of follow-up. Sporadic activity seen in ALK-negative highlights again the potential relevance of other genetic alterations in these tumors, alternative molecular driver that may be affected by crizotinib, or the limitations of the used assay that I have highlighted earlier on. Crizotinib is well tolerated, can be given over a prolonged period of time, and what I find very important is the consistency between the efficacy signal in this rare sarcoma and the effects that we see in lung cancer. So it's across entities what we find here. The definition of ALK-negative disease and role of crizotinib in these tumors certainly requires further work, but in the absence of validated treatment alternatives for ALK-positive inflammatory myofibroblastic tumors, and considering all the limitations of our non-randomized clinical trial, we propose to define crizotinib as a standard of care for patients with locally advanced or metastatic ALK-positive inflammatory myofibroblastic tumor. I want to thank EORTC, who sponsored this trial. I want to thank everybody at Pfizer who helped us getting this started, and of course don't want to forget all patients and their families for participating in the trial, and everybody in my team who supported me over the past 5 to 6 years. Thank you very much. I didn't bring this bird, actually. You want me to stay here?
Thank you. The bird was interesting. Dr. Shofsky's presentation was even more interesting. I think it shows the challenges of ultra-rare tumors and how you can make an impact. The next speaker, the discussant, is Dr. Benjamin Solomon, who heads up a molecular therapeutics laboratory and is here all the way from Melbourne, Australia.
Thanks very much. And thank you to the organizing committee for the opportunity to discuss this abstract. And I'm delighted we didn't have to wait for Dr. Shofsky to retire to hear these results. These are my disclosures. So oncogenic fusions involving the anaplastic lymphoma kinase were originally described and indeed get their name from an uncommon T-cell tumor called anaplastic large cell lymphoma. And as we heard in the previous discussion, activation of ALK has been described across a number of different malignancies through ALK fusions and also ALK point mutations. In addition to anaplastic lymphoma, large cell lymphoma, ALK is activated by fusions in non-small cell lung cancer and in inflammatory myofibroblastic tumors, but also very infrequently across a range of other common tumors. We heard about the clinical features of this rare soft tissue sarcoma from Dr. Shofsky. About 50 to 60% of these tumors are positive for ALK by immunohistochemistry. And importantly, whilst occasionally these can be cured by surgery, outcomes are very poor in patients with unresectable or recurrent disease, and historically there has been no effective systemic therapy. Crizotinib, as you also have heard, is the first-in-class tyrosine kinase inhibitor of ALK. It also has activity against the ROS1 and c-MET kinase. In the phase 1 study with crizotinib, frequent and durable responses were seen in patients with ALK-positive non-small cell lung cancer. And crizotinib and indeed other second-generation ALK inhibitors are now part of standard treatment for this population. In the same phase 1 study, a response to crizotinib was noted in a patient with inflammatory myofibroblastic tumor, which was positive for ALK by immunohistochemistry and FISH and proved to have a RAN-BP2 ALK fusion. This patient was treated with crizotinib and had a durable response. In contrast, a second patient that was with an inflammatory myofibroblastic tumor that was negative for ALK failed to respond, or rather their tumor failed to respond. So Dr. Shofsky and his colleagues went on to further evaluate the role of crizotinib in this uncommon tumor, inflammatory myofibroblastic tumor, using this study called CREATE, which is a multinational, multi-center, prospective, histology-based but biomarker-driven study to evaluate the efficacy and safety of crizotinib in advanced tumors where there's a rationale for ALK or MET activation. There were 6 different arms of this study, and the presentation today focuses on the inflammatory myofibroblastic tumor arm, which enrolled both ALK-positive and ALK-negative patients. As we heard, this was a challenging study to accrue because of the rarity of this malignancy. 35 patients were enrolled at 13 sites in 8 European countries over 5 years. A strength of this study, which is important, which was critical, was the central review of pathology. And after pathology review, 24 of the 35 patients had confirmed inflammatory myofibroblastic tumors, and 20 patients were eligible and treated with crizotinib. And for pragmatic reasons, that study closed, but nonetheless is the largest prospective study in inflammatory myofibroblastic tumors to date. Substantial activity was seen in the ALK-positive cohort of the study, with responses in essentially, or with shrinkage of tumors in essentially all patients, with an objective response rate of 50%, 6 objective responses out of 12. The responses appeared durable, and we also have available progression-free survival data. So these important data from the CREATE study are supported by and indeed validated from data from 2 other studies, one from the Children's Oncology Group and the other the Profile 1013 study. In the Children's Oncology Group study, responses were seen in 12 out of 14 children with ALK-positive inflammatory myofibroblastic tumors. In the Profile 1013 study, responses were seen in 6 of 9 inflammatory myofibroblastic tumors. So we have data from 3 independent single-arm studies in this rare tumor, which provide evidence of the activity of crizotinib in this setting. And as the point was made, in this rare tumor, it is neither possible nor, I would argue, necessary to do a phase 3 study to establish a role for crizotinib in this setting. Furthermore, the magnitude of the response, the magnitude of the response rate in ALK-positive inflammatory myofibroblastic tumors is broadly similar to the response rates seen across other ALK-rearranged tumors, in particular ALK-positive anaplastic large cell lymphoma and ALK-positive non-small cell lung cancer, arguing that the activity of crizotinib in the setting of an ALK-rearranged tumor appears to be independent of the site of origin of the tumor, at least across these tumor types. And indeed, this paradigm of tissue-agnostic drug development has extended to other oncogenic fusion kinases. Recently, data were presented with the inhibitor of TRAC, the neurotrophic tropomyosin receptor kinase, NTRAC, showing a response in a patient with NTRAC1 fusion to the TRAC inhibitor larotrectinib. And indeed, data from the combined phase 1-2 study, recently published by the first discussant, Dr. Drillen, demonstrated impressive activity across a range of NTRAC rearranged tumors with activity independent of site of origin, supporting a site-agnostic approval of this and related agents. Important also was that the ALK-negative cohort was not without activity. There was one objective response, and there was a hint of activity in at least 2 other patients. And clues of this were actually provided by our second discussant, Dr. Lovely, who sequenced 11 ALK-negative inflammatory myofibroblastic tumors and demonstrated potentially actionable mutations in 8 of these tumors, 2 ALK fusions that were missed by ALK immunohistochemistry, 4 ROS1 fusions, 2 PDGFR beta fusions. And additional studies have reported rearrangements involving RET and NTRAC, arguing for the importance of extended molecular testing in this population. And indeed, Dr. Lovely's study showed a response to crizotinib in a ROS1 fusion-positive inflammatory myofibroblastic tumor in a 9-year-old patient. So finally, CREATE is an elegantly and well-conducted basket study. It is the largest prospective study in this rare tumor type and confirms the role of crizotinib in ALK-rearranged inflammatory myofibroblastic tumors. It provides a reminder that ALK-negative inflammatory myofibroblastic tumors may also have actionable gene fusions. And the CREATE study provides supportive data that sensitivity to crizotinib occurs across a range of tumors with ALK gene rearrangements regardless of tissue site, and provides plausibility for tissue site agnostic approvals for targets like ALK gene fusions. Thanks very much.
I think we're going to need to skip the questions, and if anybody has questions, the speakers will be available because we have now cut up on our time. And the next speaker is Dr. Javeri, who will present a basket related to PI3 kinase. Dr. Javeri is a medical oncologist at the breast service at Memorial Sloan Kettering.
So on behalf of all my co-authors, I'd like to thank the organizing committee for this opportunity to present the exciting results of our phase 1 basket trial of tazelisib. These are our disclosures. So the PI3K/AKT/mTOR signaling pathway is one of the most frequently dysregulated pathways in human cancers and is implicated in tumor cell growth and survival. This pathway, one of the ways it can be activated is due to the activating mutations and or amplifications of the PI3K or the PIK3CA gene that encodes the alpha isoform of the catalytic subunit of PI3K. In fact, PIK3CA is one of the most frequently dysregulated or mutated oncogenes across a wide range of solid tumors. And shown here is the frequency of PIK3CA mutations across multiple tumor types using the MSK-IMPACT 468 gene and NGS panel. In the basket study that is being presented today, the highlighted tumor types in red, in addition to others, will be included. PIK3CA mutations are mostly common and frequently seen in the kinase and helical domains. And the frequency of these mutations differs by tumor type. For example, kinase domain mutations are frequently seen in breast cancer, and helical domain mutations are more frequently seen in head and neck squamous cell cancers. Recurrent mutations are also seen within other domains throughout the entire PIK3CA gene, but these are less frequent than the kinase and the helical domain mutations, and their functional impact is not as well characterized. Tazelisib, or GDC-0032, is a potent, selective, small molecule inhibitor of class 1 PI3K alpha, gamma, and delta isoforms with a 30-fold less potency for the beta isoform compared to the alpha isoform. A unique aspect of tazelisib seen preclinically in mutant breast cancer cell lines is that tazelisib treatment led to specific depletion of the mutant P110 alpha without significant change in the wild-type P110 alpha protein levels. And consistent with this preclinical data, clinically confirmed response rates of 36% were seen in PI3K mutated tumor patients compared to 0% in the non-mutant tumor patients in the phase 1 trial of tazelisib in solid tumors. Responses were specifically seen in 4 breast cancer patients, shown here in pink, and 1 non-small cell lung cancer, shown here in gray. Similarly, in the phase 2 Lorelei, which was a randomized trial that enrolled 300 postmenopausal women with operable stage 1 to 3 ER-positive, HER2-negative breast cancer, overall response rate, as assessed by measuring tumor size using MRI, was improved with tazelisib plus letrozole in all patients, but the combination worked particularly well in the PI3K mutated patients with an overall response rate of 56% compared to 38% seen with letrozole with placebo. Here is our study design. Key eligibility criteria are listed. Patients with PI3K mutated solid tumors with measurable disease were eligible. PIK3CA mutation was detected by either local testing or central COBAS testing. Patients with prior PI3K treatment were excluded. At least 10 patients with various histologies listed here were included in cohorts 1, to 10. Cohort 11 enrolled patients categorized as other solid tumors, which are tumor types that are otherwise not specified in cohorts 1 through 10. Now, in the prior phase 1 trial in solid tumors, the 9 milligram capsule was determined as the single agent dose. But based on relative bioavailability study, a 6 milligram tablet was expected to provide an equivalent exposure and is the dose and the formulation that was utilized in our basket trial. All patients were initially treated with 6 milligram tablets of tacilizib orally for a 28-day cycle, and a subsequent protocol amendment that allowed lowering the study drug dose to 4 milligrams to test whether a lower dose could improve tolerability. Key objectives were to assess the safety and efficacy of single-agent tacilizib. The first patient was enrolled on May 19, 2015, and at the time of the data cutoff of September 1, 2017, a total of 166 patients with PIK3CA mutations were enrolled. Based on 2 or more responses or clinical benefit noted in the first 10 patients enrolled, 4 cohorts highlighted here in yellow, including head and neck squamous cancers, cervical cancers, triple-negative breast cancer, and ovarian cancers were expanded. Highlighted here in orange are those cohorts that remain open to accrual to date. Baseline patient characteristics for all patients are summarized in this table. The median number of prior systemic therapies was 3, which is expected for late-line metastatic patients. A significant proportion of patients had received prior checkpoint inhibitor therapy, for example, 39% of patients with head and neck squamous cell cancers. As discussed, enrollment was based on local or central PIK3CA mutation testing. With the exception of 4 patients that were enrolled based on central COBAS testing, the remaining 162 patients were enrolled based on local results. Of note, central confirmation was not required for study enrollment. However, patients were treated or actually tested retrospectively after enrollment by the Foundation Medicine Next Generation Sequencing commercial assay. This slide summarizes the data for PIK3CA mutation variant type frequency by Foundation Medicine results. The most common PIK3CA mutation variant type enrolled in this basket was in the helical domain, seen in about 44% of the patients, followed by kinase domain seen in 15% of the patients, and other domains at 9%. Interestingly, 8% had more than one PIK3CA mutation, or so-called are double mutants. 10% had no mutation detected by Foundation Medicine, and results were unknown for 14%, either due to lack of tissue availability, assay failure, or pending data. Foundation 1 assay results were available for 86% of the safety evaluable patients, and the overall concordance between local and central testing was 88%. This waterfall plot displays best overall response grouped by various tumor cohorts enrolled and color-coded by the PI3K mutation variant type. Tacilizib demonstrated anti-tumor activity in a broad range of PI3K mutant tumor types. In fact, in some histologies, majority of the tumors showed tumor shrinkage, including in head and neck squamous cell cancers, in cervical cancers, ovarian cancers, and other solid tumor types. Now, looking at the best overall response grouped by PIK3CA mutation variant type and color-coded by tumor type, again you see that tumor shrinkage was observed in all PIK3CA mutant variant types, including the helical, kinase, and other domains. Patients with double mutations also responded, including a patient with Bartholin's gland, poorly differentiated adenocarcinoma, shown here in brown, and a head and neck squamous cell cancer, shown here in green. Interestingly, both of these patients had at least one hotspot mutation in the helical domain. Patients with mutations in domains other than the helical and kinase domains also achieved partial response, including one patient each with head and neck squamous cell cancers, ovarian cancer, and cervical cancer. So to summarize, Tazelicib had a broad range of activity in patients with PIK3CA mutant tumors, and the response to tazelicib varied as a function of tumor type and the PIK3CA mutation variant. This table summarizes the confirmed response rate, clinical benefit rate, and progression-free survival in tumor types that had enrolled at least 10 patients. In the head and neck squamous cell cohort, there are 15% confirmed response rate. In the endometrial cohort, the response rate was 18%, including confirmed responses in a patient with mixed Mullerian tumor and endometrioid adenocarcinoma. However, majority progressed by the time of the first tumor assessment. Median progression-free survival varied by cohort. As some patients were still active at the time of the data cutoff of September 2017, for example, 27% of patients with head and neck squamous cell cancers, PFS data is not yet mature. Nevertheless, a closer look at the activity in some promising individual cohorts is presented in the following slides. Here is the waterfall plot demonstrating best response by dose and the swim lane plot for patients with head and neck squamous cell cancers. And as you see, tumor reduction was observed in majority of head and neck squamous cell cancers treated with tazelicib. Notably, all 4 confirmed responses were seen with the 6 milligram dose. A subset of patients remained on treatment for more than 9 months, and since the data cutoff, additional patients have also stayed on treatment for more than 6 months at the 4 milligram dose. However, many patients had a duration of treatment that was relatively short, especially the non-responders. Responses in head and neck squamous cell cancers were observed with HPV positive and negative status. And of note, based on the TCGA data, we know that PIK3CA alterations are found both in HPV positive and negative patients, but more common in the HPV positive subset. It was very encouraging to see responses with single-agent tazelicib in head and neck squamous cell cancer patients who were previously treated with checkpoint inhibitor therapies. These are highlighted in orange here. And as a reminder, checkpoint inhibitor therapy has now been approved as monotherapy in second-line recurrent metastatic head and neck squamous cell cancers. And as a benchmark, the response rate for investigator choice chemotherapy beyond the second-line setting in this patient population is only 5%. Dramatic responses to single-agent tazelicib were seen in individual patients, and here is just an example of a 53-year-old male patient with HPV-positive, PIK3CA-mutated metastatic tonsillar cancer who was treated with 4 prior systemic regimens, including cetuximab and pembrolizumab, prior to enrollment on study. Shown on your left is the baseline scan and the baseline image of a 7-centimeter left chest wall mass. And as you can see, within 4 weeks, there was visible reduction in the chest wall mass, and a partial response was achieved at 8 weeks with 46% tumor shrinkage. At 16 weeks, while the partial response was maintained in the target lesion, there was unequivocal progression in the non-target lung lesion. He did undergo a post-progression biopsy that will be described shortly, as it gives insight into the mechanisms of resistance. Moving on to best response in patients with cervical cancer, tumor shrinkage was also observed in most patients, including 1 confirmed response each at 6 milligram and at 4 milligram. And duration of treatment for a subset of patients was for more than 10 months, including 2 patients treated at 4 milligrams, suggesting that 4 milligram may be sufficient for some activity, and that could depend on tumor type. Within a broad categories of tumor types, there may be further variation in response to tazelicib based on histology. Shown here is the best response in patients with ovarian cancer, and as you can see, most patients with clear cell histology, indicated with a green triangle, had tumor shrinkage, albeit without any confirmed responses in this group. Shown here again is a dramatic response for a 52-year-old patient with ovarian clear cell carcinoma with a 1047R mutated tumor. Baseline images are shown on your left, and visible reduction was seen in the large abdominal mass at 8 weeks with 51% tumor shrinkage in this patient. Among patients enrolled to the other solid tumor cohort, 5 out of 51 patients had a confirmed response, which were seen in a variety of tumor types, including 1 patient each with gallbladder cancer, pancreatic sarcomatoid, pancreatic pseudopapillary, biliary adenocarcinoma, and parotid mucoepidermoid adenocarcinoma. Additionally, after the data cutoff of September 2017, 1 patient each with extramammary pages of the vulva and scrotum also achieved partial response. The clinical benefit rate in this cohort is about 21%, and some patients remained on single-agent tacalafit in this cohort for over 20 months. Safety overview is summarized for the 122 patients treated at 6 milligrams and 44 patients treated at 4 milligrams. 30% of the patients treated at 6 milligrams had adverse events leading to dose reduction, compared to only 13% at 4 milligrams. As expected, patients treated at 6 milligrams also had a higher frequency of grade 3 and serious adverse events. 2 out of 9 adverse events with fatal outcome were deemed related to tacalafit by the investigator, including a case each with grade 5 septic shock and grade 5 pneumonia. The overall safety profile suggests that the 4 milligram dose was better tolerated than the 6 milligram dose. However, one caveat is that the follow-up is shorter for the 4 milligram dose patients. Adverse events of special interest with tacalafit were consistent with those that have been previously observed, with no new safety signals identified. Numerically higher frequency of grade 3 diarrhea, colitis, rash, and stomatitis were seen with the 6 milligram dose compared to the 4 milligram dose. Pneumonitis was observed in both 6 milligram and 4 milligram cohorts. However, 2 patients treated at 6 milligram had grade 3 pneumonitis. Now, post-progression biopsies are a very valuable way to better understand mechanisms of resistance. The same head and neck squamous cell cancer patient with a dramatic left chest wall mass, as previously described, underwent both pre- and post-progression biopsies while on study. Of note, he was deemed eligible for this study based on the local MSK impact results from the peri-aortic mass, which was done in October of 2014 and yielded a E542K mutation. This mutation was also retrospectively confirmed by Foundation Medicine, both from the peri-aortic mass and the pre-treatment left chest wall mass. At progression, a biopsy was obtained from the non-target right lung lesion and analyzed by Foundation Medicine. These results detected a LKB1 or STK11 S216F mutation that was not seen at the initial biopsy. There was insufficient tissue from the right lung biopsy to also run a local MSK impact panel, so an additional tissue was obtained from the left chest wall 2 weeks later, and then the MSK impact panel detected 2 deleterious nonsense mutations of PTEN. Corresponding immunohistochemistry shows focal loss of PTEN in the progression sample, and as shown in the pre-treatment sample from the left chest wall, there was diffuse PTEN staining. Of note, no PTEN mutations were detected from any of the samples tested by Foundation Medicine, pre or post, and STK11 mutation was not detected by the MSK impact testing. However, both STK11 and PTEN mutations are associated with reactivation of the PI3K-mTOR pathway. And loss of PTEN has also been previously reported in a patient with metastatic breast cancer treated with the alpha-specific PI3K inhibitor alpelisib. Together, this suggests that treatment with PI3K inhibitors results in selection of alterations that can reactivate the pathway, underscoring the importance of this pathway. So in conclusion, this study represents the largest basket study reported to date of PIK3CA mutant tumors treated with a mutant-selective PI3K inhibitor, tacalafit. Tacalafit has clear activity in PIK3CA mutant solid tumors, and response to tacalafit in PIK3CA mutant tumors varied as a function of tumor type, PIK3CA mutation variant, and dose of tacalafit. Confirmed responses were seen in head and neck squamous cell cancers, cervical cancer, endometrial cancer, and other solid tumors, including in those who have progressed on checkpoint inhibitor therapy. However, among patients who respond, responses were typically partial and not sustained, likely reflecting clonal heterogeneity, presence of other driver mutations, and emergence or selection of resistance pathways, including reactivation of the PI3K/AKT pathway. There were no new safety signals, and higher doses were associated with increased anti-tumor activity, but decreased tolerability. Improving the clinical efficacy of targeted PIK3 inhibitors will require strategies to, one, better understand the mechanisms of resistance and how to target those mechanisms. Second, to identify safe combination therapies. And lastly, improving the therapeutic index with development of both isoform and mutant-selective inhibitors to allow for sustained pathway inhibition in mutant tumors without compromising exposure due to adverse events associated with inhibition of the wild-type PI3K alpha isoforms. With that, I'd really like to thank all the investigators and the research staff at the 21 centers that were involved in the study. Specifically, like to thank all the patients who participated in this trial and volunteered for all the biopsies, their families, and the entire study team at Genentech. Thank you all for your attention.
Well, thank you. PI3 kinase is certainly a tougher target. And Dr. Timothy Yap from MD Anderson Cancer Center will be the discussant of that interesting study.
Thanks very much, Dr. Kurzweil. Good afternoon, everyone, and thank you all for being here, and thank you for staying to the bitter end. I'd like to thank the organizing committee for giving me this opportunity to discuss this abstract. These are my disclosures. So first, I'd like to congratulate all of the investigators for an excellent study, especially Dr. Javeri for an outstanding presentation, and also to thank her for setting me her slides in a very timely fashion. I've listed here in this table all the PI3K inhibitors that have been in development, and they're divided on the table by the mechanism of action. So you essentially have the dual inhibitors at the top against PI3K and mTOR, the pan-class 1 PI3K inhibitors in the middle, and the isoform-specific PI3K inhibitors at the bottom. And you'll see over here in this column that back in 2012, which wasn't too long ago, all of these drugs were still in active drug development, either in the preclinical or clinical setting. But you'll also see in the next column that over the past few years, really the dual inhibitors and the pan-class 1 inhibitors have fallen by the wayside. And it's really now down to the isoform-specific inhibitors to really continue the fight in targeting PI3K in cancer. And this includes tasilisib, which is the topic of our discussion today. So one of the main issues in targeting PI3K is drug resistance with single-agent PI3K inhibitors is inevitable. And this is due to multiple reasons, including the development of signaling crosstalk, disruption of feedback loops, and other compensatory mechanisms. There are also issues of heterogeneity and also other resistance mechanisms that we need further research into. And therefore, for me, the key priorities for targeting PI3K are really the qualification of predictive biomarkers, optimization of doses and schedules of our current agents, and also the development of new and potent isoform and mutant-selective inhibitors, and to also develop rational combination strategies moving forward. So this basket study follows on from the phase 1 dose escalation study that was led by Dr. Jurich and Dr. Baselga. You'll see that there were 3 PRs, confirmed PRs at the higher doses, but these doses were not tolerable with the observation of DLTs and also chronic toxicities. At the lower doses, 6 milligrams was predicted to be the minimal efficacious dose from preclinical studies. And on this study, the investigators showed that 3 milligrams and above was enough to show tumor PD modulation. And eventually, 9 milligrams of capsules was deemed as the recommended phase 2 dose based on toxicity. As mentioned by Dr. Javeri, tasilisib was then switched to tablets, and a bioavailability study confirmed that the new 6 milligram tablets were the equivalent to the 9 milligram old capsules. And therefore, this basket study started off at 6 milligrams QD of the tablets. But recently, they've reduced this down to 4 milligrams of the tablets because of concerns over tolerability, as shown in this table here. You'll see that at 6 milligrams, 60% of patients experienced toxicities that actually resulted in dose modifications or interruptions. And also, about 40% of patients also experienced grade 3 related AEs. And therefore, for me, the key question is, will the lower dose of 4 milligrams QD still be as clinically active as 6 milligrams QD? And ultimately, is 4 milligrams QD, the lower dose, is it going to be well tolerated by patients? Because if you look at these numbers here, 43% still experience AEs that actually result in dose modifications and interruptions. And 1 in 5 patients actually experience drug-related grade 3 or greater AEs. And for me, my main concern is over chronic toxicities, which is likely to be a feature of continuous dosing of this drug. And therefore, I just wonder if an intermittent schedule, say of 6 milligrams, may actually improve the toxicity, or whether this will simply compromise efficacy. And what about an individual patient dose titration strategy that's guided by patient toxicities? Perhaps start the patients at 4 milligrams and actually go up to 6 if patients are tolerating this well. Ultimately, the future of tocilizumab is most likely to be in combination strategies, and therefore alternative intermittent doses are probably going to be required. This is a well-designed basket study, and the choice of each basket of tumor type was really based on the frequency of the individual tumor PIK3CA mutation rate. Of note, there were no HR-positive breast cancer baskets or non-small cell lung cancer baskets due to overlapping competing studies. There were also no CNS tumor baskets due to poor brain penetration, as evidenced by preclinical data for tocilizumab. And ultimately, 4 of these cohorts actually met their pre-specified criteria and expanded. In this multi-center study, any PIK3CA mutation was eligible, and that was regardless of actionability. And therefore, the potential implications for anti-tumor response. I therefore enlisted the help of our genomics precision oncology decision support team, and you'll see that a total of 32 PIK3CA alterations were observed on the study, and it was suggested that 17 of them are truly activating and actionable. 13 of them are variants of unknown significance, which are still deemed potentially actionable, and 2 were VOSs with unknown actionability. But what really fascinated me were these double mutants, as you can see in the middle column. And we certainly need more information to try and determine if these mutations are actually within the same or different clones, whether they're in cis or trans within a single cell, and whether these double mutants actually result in possible combinatorial functional effects. And I'll be also very curious to see if these actually arose out of drug selection pressures. But ultimately, not all mutations are equally actionable. And it's absolutely crucial that our different genomics decision support teams continue to play a crucial role in delineating the actionability of these different variants. It also stresses the importance of robust functional genomic studies as well. On the study, the single-agent responses to tocilizumab were indeed very promising, but the benefit, as mentioned earlier, was not durable. As evidenced here with head and neck cancer patients, there were 4 confirmed PRs, but only 3 of these patients stayed on trial for greater than 6 months. And therefore, we really need better strategies to try and deepen and lengthen the responses in a greater population of patients. And to do this, we really need better biomarkers, we need better drugs, and we also need to think about undertaking a longitudinal, biomarker-driven, rational combination strategy. And one approach could be a reversal of resistance approach, where you actually biopsy the patient up front, molecularly profile them, and start them on an appropriate drug like tocilizumab, track them with ctDNA, at disease progression, you essentially repeat the biopsy again and molecular profiling, add on a second drug in combination that actually inhibits a compensatory pathway or feedback loop. You could also do a sequential approach where you start off with the biopsy, start off with the combination, track the patients with ctDNA, at disease progression, stop the combination, repeat patient selection again with a repeat biopsy, and switch the combination to one that actually targets a different signaling pathway. And a variation to this is simply to add on a third drug to do a triplet combination with a drug that actually inhibits a resistant signaling pathway. And moving forward, perhaps in future, we could actually do away with CT scans and actually use rising allele frequencies from ctDNA to actually guide the triggering of a tumor biopsy. And perhaps in future, we could actually do away with painful invasive biopsies and actually leave it to the rising allele frequencies as shown by ctDNA to actually guide the switch in therapy. This would look something like this, where we would use fresh, minimally invasive, multiple ctDNA to really guide the patient journey in the clinic. Are we there yet just now with ctDNA? Obviously not, but it's something that we should all be aiming for. We should also try and push the boundaries by considering triplet combinations. A good example is the combination of tocilizumab, palbociclib, and endocrine therapy, which was shown by Nick Turner's lab at the AACR to be synergistic in preclinical models. And this work actually led to an investigator-initiated phase 1 trial at the Royal Marsden Hospital that Nick and I led, initially of the doublet of tocilizumab and palbociclib before endocrine therapy was added on. And you'll see here a patient with metastatic breast cancer who harbored a PIK3CA 1047 mutation, and she had a durable response to the doublet therapy. We should also think about other treatment modalities such as radiotherapy. Dr. Baselga's lab has actually shown that tocilizumab radiosensitizes head and neck squamous carcinomas that harbor PIK3CA alterations. And I show here the in vivo efficacy of this combination in KEL33 head and neck squamous carcinomas, which actually harbor a PIK3CA H1047R mutation. And you'll see in this red curve here that tocilizumab enhances the efficacy of fractionated radiotherapy in vivo, in contrast to the control vehicle, in contrast to single-agent radiotherapy, and also single-agent tocilizumab. And last of all, how about PD-1 combinations? I had to ask that question. Well, we all know about the immune-related effects of PI3K inhibition. And I show here this figure which shows the effects of inhibiting the different PI3K isoforms. And one shouldn't actually forget that tocilizumab is actually a very potent inhibitor, not just against alpha, but also against gamma, especially against delta as well. And delta inactivation in Tregs has been shown to unleash CD8 cytotoxic T cells and to also induce tumor regression. And the inhibitors have also been shown to break tumor-induced immune tolerance. And therefore, to me, combining PI3K and PD-1 inhibitors is a rational combination. So I'm going to leave you now with my take-home points. Thank you very much for your kind attention, and again, many congratulations to all of the investigators. Thank you very much, and good night.
Well, our time is up. If there's anybody that has any questions, feel free to ask, but we have the investigators here. I actually had one question for you. What about KRAS? It often resides with PI3 kinase. Could that not be your mechanism of resistance, which actually makes it pretty difficult?
So that certainly can be a mechanism of resistance. And in fact, in the phase 1 trial of tocilizumab in solid tumors that Dr. Yap reminded us of, that was published already in Cancer Discovery, in colorectal cancer cohort patients that had concurrent KRAS mutations, there were understandably no responses seen. So yes, in certain tumor types, specifically like colorectal cancers, concurrent KRAS mutations will be a problem with response rates. We still don't have all the data for concurrent mutations from Foundation Medicine for our data set, but something we will be certainly looking into deeply.
Okay, thank you everybody, and I think this is a very excellent session, so thank you to our speakers and to our audience.